Hi, good morning, everyone. Welcome to the Women's Health and Fertility Roundtable. It's an honor to be here with everyone today. I'm Deborah Sheldon, Vice President of MAHA Institute. I first want to start with a very heartfelt welcome and thank you to our co-hosts, the Heritage Foundation, Emma Waters, and Dr. Jay Richards. First, just want to thank you so much for the opportunity to collaborate and for all of your support, and also for your vision and leadership. I want to thank the MAHA leadership, Mark Gorton, Tony Lyons, Lee Marinoff, and also Maddie Garvey for all of her incredible support pulling this event together. I want to also thank our panelists who've traveled from across the United States and Canada to be here with us today. Members of the administration, elected officials, MAHA supporters across the country, and especially Secretary Kennedy and the HHS leadership. We're lucky to have Dr. Sarah Brenner with us today. Sarah is a preventative medicine and public health physician, serving as the Principal Deputy Commissioner for the United States Food and Drug Administration, where she provides leadership and direction to the whole of the agency aside the commissioner. Thank you, Sarah, for being here. The challenges we're facing are very real in the United States of America with regard to women's health and fertility. Fertility rates, as many of you know, are plummeting, and our birth outcomes are among the worst. The label safe and effective has all but lost its meaning for many Americans, and mistrust in healthcare is growing. Women are often left unprepared to make what we would consider truly informed consent or choices about their health. And we know that maternal health is inseparable from the health of our children and families. However, there's an amazing opportunity. Young women, MAHA moms, are leading the charge, seeking answers, reclaiming their vitality and life force. And the MAHA movement, as I see it, is pretty much sweeping the country. And we also know that finally, for the first time in a very long time, policymakers in Washington, D.C. are not just listening, but also responding. Many who sparked this movement serve in the administration, and this gives us a very unique moment to tackle these issues at their root, both holistically and with a great deal of courage. And I know many of you in this room have been a part of that movement, and I thank you for the courage to speak out when it was a very challenging thing to do. I think that we're witnessing a very profound shift in our culture from a culture of obedience and handing over authority over our bodies to one of inquiry, connection, and harmony. Secretary Kennedy and the HHS leadership are ready to embrace ideas as they've made a commitment to the highest standards for health and reform. So I guess my call to action for all of us is let's claim this moment. Let's build the system that truly uplifts healthy mamas, healthy mothers, healthy babies, and healthy families. And together, I think we're in a great position to restore trust, empower women, and create a future where health is once again our greatest strength. Thank you so much.
Good afternoon, everyone. My name is Emma Waters, and I'm a policy analyst at the Heritage Foundation. First, let me mirror Deborah's remarks and extend a warm thank you to the MAHA Institute, to the Heritage Foundation, and at the Heritage Foundation, Dr. Jay Richards with the Restoring American Wellness Project for co-hosting such an important event today. We've gathered today not just as experts and advocates, but as people who care deeply about the flourishing of families in the United States of America. And on a personal note, I want to thank my mother for coming into town this week. She's caring for our 2-year-old and my 6-month-old. And without her, this really wouldn't happen. And I think it further reinforces the intergenerational power of this movement, that it's not just us individuals in Washington, D.C., but it's mothers and grandmothers and children across the United States who make it up and make it possible for us to do this work. It is no exaggeration to say that this is a historic political moment. For the first time, the White House and top political leaders are directly spotlighting family formation, real reproductive health, and root cause infertility care as national priorities. This is no small shift. It's a recentering of policy around some of the most deeply human and pressing issues of our generation. We all know the facts. It often takes women years to receive a diagnosis for their reproductive health conditions like endometriosis and PCOS. Up to 30% of infertility cases are simply deemed unexplained. And for too long, the medical system has offered Band-Aid solutions to manage symptoms rather than treating the root causes. Women, especially younger women and mothers, are asking, is this really the best we can do? And thankfully, the answer is no. A better way is not only possible, it's already emerging. And here's what's remarkable. It's not top-down reform. It's a grassroots movement led by mothers and Gen Z women who are saying enough is enough. They are challenging outdated models of care. They're asking better questions. They want care that treats the whole woman, respecting her body, her story, and her hopes for the future. That movement is no longer confined to private conversations or social media where it began. It's taking root right here in Washington, D.C., and it's beginning to reshape how our country thinks about women's health, infertility, and the family. And this is not just about helping families have the children they desire. It's about supporting healthy families, starting with healthy men and women. Now it's time for a new women's health movement, one that draws on all we know about the incredible design of the female body and the tools of modern medicine to support fertility and reproductive health, not override it. Women deserve a deep understanding of how their bodies work, and they deserve access to care that treats the root causes of reproductive health conditions, not just care that manages symptoms or bypasses them entirely. In this new world, innovation must serve, not replace, the human person. True innovation does not pit women against their fertility, mothers against their children's health, or families against economic survival. Rather, it empowers people to understand, steward, and heal their bodies. And that's the promise of holistic fertility care that we are discussing today. This approach channels the latest developments in medical research, metabolic health, and much, much more to identify, diagnose, and treat the root causes of infertility and reproductive dysfunction. Indeed, the phrase unexplained infertility should be a thing of the past. We can and should expect more of women's health care across the board. But innovation doesn't happen in a vacuum. Public policy plays a critical role. We need to remove outdated regulatory barriers. We need to incentivize real research into reproductive health, not just symptom management. And we need to align insurance and coverage models with long-term wellness, not just short-term fixes. And finally, if we're serious about addressing the fertility crisis, we must treat it as the national priority that it is. There is no single silver bullet solution, but there are powerful, tangible steps that we can take right now to provide better care, better diagnostics, better clinical training, and better research investments that reflect the dignity of the human body and the essential role of the family in our society. And we need to keep listening to the mothers, the patients, the advocates, and especially the young women who have taken it upon themselves to speak out, to seek answers, and to lead in this new women's health movement. Because this movement didn't start in a lab or in a think tank. It started in living rooms and doctors' offices. It started with women saying, we deserve better care, and our families deserve a better future. Now, it's our job to deliver on that future. Thank you.
Wow, that was so good. How do I follow that? Wow, can I just do +1 on that? I was joking earlier that regulation isn't always fun. That's a joke, but it's not really funny. This is fun. Like, this is incredible. I can't even tell you how much I love every topic that's going to be discussed today. The fact that we're having this conversation, as you described, with the cross-section of women and leaders and moms and thinkers to come up with a new way of approaching problems, challenges, and opportunities for women. It's just like getting to do these events and engage with communities like this is what makes the job fun. I'm joining you not just as a regulator with the FDA hat, but also as a mother of 3 wonderful sons, a sister, a wife, and a daughter. So, forgive me if I take the FDA hat off and keep it real here with some of the comments. I've spent a lot of time in different realms of career. I'm a preventive medicine and public health physician, so I joked at the last MAHA event that I was MAHA before there was MAHA and couldn't, get the T-shirt created fast enough when this started coming together. I've long thought, since I took a pivot from internal medicine to preventive medicine and public health, that we need to be upstream on disease. I didn't particularly enjoy seeing, diagnosing, and writing prescriptions for the same 5 to 7 chronic diseases all day, every day in internal medicine. Preventive medicine and public health really has been swimming upstream in the medical system, as this crowd would definitely already be aware. What I never thought I would see in my career is an opportunity like this, with this type of focus from our White House, from our secretary, from our commissioner, and from NIH leaders, CMS leaders, the leaders, appointees, and career civil servants across the whole of the government to focus on these issues and elevate them, and work with stakeholders on real solutions, not just a list of problems that get talked about for 4 years or more, but bringing people to the table and saying, we want to solve these things, and people demand solutions to these things. So that is truly a divine intervention, I think, is what's gotten us here, perhaps many of them. I was also a technologist in a previous life. I was a tenured professor in nanobioscience and nanotechnology and led a nanomedicine program. So I'm very aware of both the promise and the potential perils of technology for women and for all humans. I used to teach classes on societal implications of technology. And I'm sure those topics will come up here as we talk about various health tech and femtech and metabolic devices and this and that today. I took my role as a faculty member first as an educator and a teacher, and now still doing that to a large extent as a parent, but also as a regulator. I think it's important that folks like us share and communicate and educate others and have that true, open, and honest dialogue. I spent some time in health policy at the White House for a couple of years and worked on biotech and human health, and now found myself at FDA, an innovator in regulators' clothing. At FDA, we focus on women's products that are used by women, across the entire lifespan of women. We have a few different initiatives that I'll just mention here. We're working on ways to advance the science of collecting data, specifically through inclusion of women in clinical study designs and analysis, advancing biomarker science, expanding methods and approaches for improving the quality of data that we obtain from participants, especially women, different sources and analysis methods, and ways of communicating with women in their role as a society member, but also in the other roles they serve in life. As I mentioned, that I have mother, wife, sister, caretaker, daughter. We interact with people that we love, community members, and help influence a lot of health decisions, including the use of medical products that are regulated by FDA every day. We probably don't even think about how many ways and how many times we do that, but we do. We're also looking at promoting the use of emerging technologies and methods in a responsible, ethical, moral way. And that includes informed consent, which is a big theme that people maybe have heard me talk about before, that I'm very passionate about. We also take into consideration emerging health threats and trends and the unique role of women in society and looking at those situations. Just to close, I'll hit on a few high-level themes that are guiding principles for us right now at FDA, and I also know at HHS. One is transparency, and communicating and sharing with people exactly what the information and evidence is that's informing our decisions. Of course, it doesn't happen overnight. I wish you could just go into the control center at FDA and flip all the lights on and all walls become glass. Of course, we deal with a lot of proprietary companies, intellectual property types of information that we can't disclose. But for other aspects, my hope and our goal is that we're as transparent as we can possibly be legally with the public with regards to the products that are going to market and available to patients. Related to that, I mentioned, is informed consent. You can't truly have informed consent unless physicians and patients have information about risks and benefits, and the data and clinical evaluation that underpinned decision-making about products going to or staying on market. This sounds obvious, but it's not always the way that things have operated. So we're working on that as quickly as we can. The other few items you've heard the Secretary talk about quite a bit, near and dear to my heart, prevention and disease reversal, so chronic disease reversal. In internal medicine, we talked about chronic disease treatment all day long. I'd love to shift the conversation to chronic disease prevention and reversal through technology, through lifestyle interventions, through any means that help people achieve their optimal health for over the course of their lifetime. And of course, children's health. I know this is a women's health event, but children are inside of women's bodies, obviously, and then part of their body as an extension of their body. And I remember when I was breastfeeding all of our children, I thought, you know, this isn't so much different than the baby still in the body. They're still on my body. Like, they're an extension of body for quite some time, and their health is dependent on the mother's health from before conception through, childhood. And so you really can't dissociate that dyad and just talk about the woman or the baby, although in conversations I won't specifically mention, often there's just a focus on the infant, like as if they just came out of thin air. It's like, no, they came from another human, 2 humans actually. But in any event, we need to start addressing these concepts of health more holistically and approach solution making in the same way. The last bit, and I know other speakers will talk about this in the roundtables, is really bringing it all home is empowering women with information to take ownership of their body. And when I was, seeing patients in the ER and triaging them, they'd be their chief complaint. What are you here for? It's a backache, it's a gunshot wound, it's whatever. And they're like, any other problems? No, I'm fine, nothing else. So you do the review of symptoms, which you do when you're training, and it lights up like a Christmas tree. Really? Okay, you got a leg hanging off, you've had a cold for 5 weeks. So people, unfortunately, don't have the level of awareness that they have a body, that the body, has symptoms that are related to something going on and can tell you a lot about your health, and that there are things that you're choosing or not choosing to do, or environmental exposures that you have. There's a whole milieu of things that you could be aware about and informed about and making decisions about to improve your health and optimize your quality of life for as long as possible. That's kind of the undertow of what I feel like this movement is. It's an awakening to self, and it's a regrounding on the entire human person, mind, body, and soul. And I love it. So thank you for inviting me today.
Hi, everyone. Thank you, everyone, the people who invited me. Thank you for the folks at the Heritage Foundation and the MAHA Institute. I am Sarah Hill, and I am a research psychologist. I've spent the last 25 years of my life studying women, women's brains, and women's psychology. I'm also the author of the book, This Is Your Brain on Birth Control, and the forthcoming book, The Period Brain. And in addition to these roles, I also serve as a science advisor for tech companies like 28 Wellness and Flow Health. I am somebody who is very passionate about the idea of body literacy. And most of my forward or outward facing work is aimed at educating women about their hormones and the profound role that they play, not only in things like reproduction, but also just the function of the brain, right? Who they are, a woman's identity, right? And all of this is core at being able to offer informed consent when it comes to any sort of a medication, especially a medication that impacts hormones like the birth control pill, right? There's so little that women know about the way that their brains and bodies work that it's really impossible to offer a woman a medication that has an impact on their brains like the birth control pill does, without being able to provide the educational background necessary, and that's something that the work that I do tries to bridge. I'm essentially trying to teach women the things that nobody else taught them, so that way when they're making decisions about things like the pill or hormone therapy, they're able to do so in an informed way. Another passion point for me is that of increasing research on women, right? Because we can't teach women about their bodies when we don't actually know about them, right? And the fact of the matter is, most research science has been set up in a way that's been designed to study the male body and the male brain, right? And what this means is that most of the things that we know about everything ranging from the way that the immune system deals with bacteria to the risks for Alzheimer's disease have been studied in male models, right? And so this is male animal models or male humans. And the fact of the matter is, female bodies are different than male bodies, right? And the way that our bodies deal with bacteria, for example, are sex differentiated, right? Women's immune systems, because of the profound impact that pregnancy has, right, on the functioning of the immune system, which it does, because if your body thinks that something that's rapidly developing in the body that is non-self, right, the fact that our immune system will leave that alone, right, requires a lot of changing of rules, and that's what our hormones do, right? Our hormones shift the rules that our body follows in everything that, like from how our cardiovascular system works to the way that our immune system works, and so on and so forth. So female bodies do things differently than male bodies do, and most of the research that's been done up until this point has been done on male bodies. And now that females are actually included in research, because 25 years ago, the NIH required that researchers include some women or some females in their research. Now females and women are included in research, but in small numbers and not in large enough numbers to actually look for sex-differentiated outcomes. And the thing that this, of course, causes problems, right, because male bodies and female bodies are not the same, right? And so we know very little about female bodies. Right, and we know even less about female bodies than you might think, because now that females are included in research, the way that researchers dealt with the issue of the fact that female bodies are different than male bodies is they decided that we need to study females only when they're maximally male across the cycle. And so what this means is that when researchers study women, they do so in the first 5 days of their cycle when hormone levels are low. This means we know almost nothing about the way that the female body responds to anything during the progesterone-rich phase of the cycle, known as the luteal phase. We know very little about how women's bodies respond to things during pregnancy. The only things that we really know about how women's bodies respond to things are when women are maximally male. So, body literacy requires not only education, it requires absolutely scrapping the way that science used to be done and changing the rules, right? And changing the rules in a way that allow women to be studied as women, right? And so I don't have a really nice, neat bow to put on everything I just said as a closing statement, but I'll just, I guess, close with this, and that is that, the future of women's health is about understanding that women's health isn't just gynecology, right? It's about the health of women. So thank you.
So Sarah, what you've convinced us is that science really isn't science anymore, right? And yeah, it's made up. And so how do you have evidence-based medicine when the evidence is crap? Hi, everybody. I'm Stuart Fishbein. I practiced obstetrics for 40 years, 28 in the hospital setting as a private practitioner in Southern California. And the next 12 and a half years I spent assisting families in home birthing. I began doing home birthing partly because the hospital was no longer tenable for me. They began to ban VBAC. They began to ban breech delivery. I was working collaboratively with midwives. They banned the midwives. And I didn't want to get into a legal battle with them, so I decided to leave, and it was one of the best decisions in my life, because for 12 and a half years, I helped women have breech babies at home, twin babies at home. I had type 1 diabetic moms have them at home, hypertensive moms have them at home, because the model that we're taught in a medical school and residency is not a model that really applies to most women. I'm now retired from clinical practice, but I host a popular weekly podcast, and I'm actively teaching breech and twin skills around the world to honor choices in women's autonomy. I want to start out a little bit today. Oh, first I want to thank Deborah and Emma, and of course Maddie and MAHA Foundation for having me here. It's really an honor to be here. Just a bit of history. In 1970, not too long ago, the United States had a cesarean section rate of 5%. Almost no mother was induced in labor. Less than a third had ever had a single ultrasound. There was no routine screening for diabetes or group B strep. There was only amniocentesis for genetic testing, and it was used sparingly. Breech and twin vaginal birth were routine and taught as a core skill. There were no vaccines given to pregnant women. Continuous fetal monitoring did not exist. The Friedman labor curve was in its infancy, and newborn intensive care units were barely a thing. Everything was paper charted, and the idea of electronic medical records was unimaginable. The American College of OBGYN, founded in 1951, in 1970 had no guidelines, zero. There was no high-risk specialty in obstetrics, now known as maternal fetal medicine, and having a baby was a special time of joy and wonder and family. In 1977, the Society for Maternal Fetal Medicine was established and describes itself as a not-for-profit organization, I'll let you think about that for a minute, dedicated to improving maternal and child outcomes. That was in 1977. Since the founding of the Society of Maternal Fetal Medicine, the United States cesarean section rate has risen 600% to about 34% of pregnancies. Since 1990, the rate of induction has tripled to more than 30% of women. Most women have multiple ultrasounds now, including the use of high-intensity, non-ionizing radiation color flow Doppler. Diabetes, prenatal genetic testing, and GBS screening are routine. 98% of breeches and 75% of twins are not offered a vaginal delivery. 4 vaccines with 6 antigens are strongly recommended by the American College of OBGYN. Continuous fetal monitoring is now hospital policy, and vaginal exams to plot progress on a labor curve are the norm. The rate of postpartum hemorrhage has doubled in the last 20 years. Newborn intensive care unit admissions have nearly doubled in the last 15 years. Electronic medical records are now mandatory. ACOG now has hundreds of guidelines. And there is rarely a mother who makes it through the standard obstetrical pregnancy without consultation with a maternal fetal medicine specialist, projecting a lot of fear and anxiety onto our mothers. If, as we are told, the goal of the specialty, maternal fetal medicine, is, quote, dedicated to improving maternal and child outcomes, unquote, which is in their statement, you must believe that all the advancements I just described are beneficial and they must surely lead to a commensurate improvement in outcomes. But we'd all be wrong. The rates of stillbirth, cerebral palsy, and neonatal morbidity have not improved since 1970. We spend more per capita on care in the United States, yet the neonatal death rate ranks 54th in the world. The rate of maternal mortality and morbidity has risen, and reports of mothers feeling unsupported and with emotional trauma are now common with lasting downstream consequences. Our children and women are less healthy by nearly every measure. Our immune health begins in the womb, and how we are born can set the stage for a lifetime of health or chronic illness. The pharmaceutical-based intervention-filled model of medicalized birth has not led to better outcomes, as evidenced by the 55 years of history I just went over. In fact, there's good evidence to suggest that the obstetric model of care has negative efficacy. They have replaced the innate normalcy of pregnancy and birth with a fear-based approach that interferes with nature's design. A mammal needs to labor alone, where she's safe, quiet, and unobserved. Right? Pretty much everything that's done from the moment, not even talking about prenatal care, from the moment a woman gets into the car and drives to the hospital in early labor until she puts the baby in the car seat to drive home, everything that's done to her is antithetical to nature's design. Things that you do to the woman in labor you would never do to your dog or your horse or your cat if they were in labor. We have seen a meteoric rise in interventions over the past 50-plus years: labor curves, fetal monitoring, ultrasound, induction, cesarean section, epidural anesthesia, without any commensurate improvement in outcomes for mothers and babies. In fact, there is good evidence, as I said, of non-benefit. If we are truly interested in the MAHA or make America healthy again, then a sea change in the approach to pregnancy is necessary. We should return towards the principles of wisdom of traditional midwives, the true experts in normal birthing. And I know this because I did spend almost 30 years working directly with midwives, the first bunch in the hospital and then in the home setting. I'm in a very unique position because I lived in both worlds. Doctors who work in the hospital criticize home birth. Some home birth people criticize hospitals, but a lot of times there's no crossover. What we need to do is break the silos. We need to have women who are using a home birth midwife. The midwife should be able to go to the hospital and spend some time there. Third and fourth year medical OB residents should spend time with a home birth midwife. We should cross over. We should break down these walls. We should return toward the principles of wisdom and traditional midwives, the true experts in normal birthing, while we preserve the hospitals for only those mothers and babies that truly need it. As MAHA moves forward, it would be a huge mistake to rely on the organizations and academic institutions that got us into this mess, which I'm talking about the Society of Maternal Fetal Medicine and the American College of OBGYN, and I could throw in the American Academy of Pediatrics in there as well. Institutions that ACOG will fight to hold on to power and claim dominion over the midwifery, which they're already doing, and they claim dominion over the birth industry. We don't think that that should happen, and we hope that the press will ask ACOG some tougher questions. Stop fawning over them. They're not representing what most women need. We are excited to be a new coalition of health professionals with a proven track record of better results. And as a group, we are ready to fill that leadership vacuum in maternity care. So thank you.
Hello, everyone. My name is Grace Emily Stark. I'm the editor-in-chief of naturalwomanhood.org. We are the online magazine of women's health and fertility awareness. And I can tell you, just in the last 6 months, that visits to our website have doubled. Women are hungry for knowledge of their bodies. And it should start before they have their first periods. What we have here is a systemic lack of knowledge for women about their bodies. 44% of girls start their first periods with absolutely no idea what's happening to them. Only 13% of adult women can correctly identify when they're ovulating. And 28% of teens and women on birth control are on it for menstrual cycle regulation with no idea that it's actually menstrual cycle suppression. These women all have the same tragic thing in common, which is that they've been systematically denied the knowledge of their bodies, particularly that of their cycles and fertility, which is their birthright as women. This denial has made them fear their cycles and fertility, to see them as unpredictable, unreliable, and ultimately, and most heartbreakingly, as signs of brokenness and weakness. In our fear, we've been taught to suppress our cycles with hormones and devices that wreak havoc on our minds and our bodies and do nothing to heal the underlying causes of painful periods, infertility, and so much more. It's past time to empower girls and women with body literacy tools that are needed to understand their fertility and their cycles, to give them the language to advocate for care that respects the brilliance of their female bodies and works with their natural design rather than against it. Women deserve to know that such care exists and that root cause treatments are available to them, and to be given access to medicine which understands that a woman's menstrual cycle is truly her fifth vital sign, impacting so much more than the regularity of her monthly bleeding or her ability to get pregnant. We would never accept a cardiologist who presented with a patient with an irregular heartbeat to suggest that we just shut down the heart, right? Today is the day that women start demanding the same standard of care when it comes to their reproductive health. Thank you.
Hello, everyone. I am Dr. Kimberly Corey. I'm a family practice board-certified physician and also board-certified in a type of restorative reproductive medicine called naprotechnology. And I've been in practice for over 30 years, and about the last 20 years, I've done a combination of RRM, that's, oh my goodness, restorative reproductive medicine, and functional medicine, which seeks to find the underlying cause. They're a perfect match because they're both looking at underlying causes of health. And it's this combination that I think has just been fantastic for women. Now, what I'm going to talk about today, many of you in the audience know because some of you are practitioners. But this is geared for people who don't know, the people who don't understand what it is. So for those of you who know, bear with me. For those of you who don't, I hope this is helpful for you. RRM is a type of medicine that is scientific, holistic, and comprehensive. It works in harmony with the woman's cycle, and it empowers her to take charge of her health. And it does this by helping women identify biomarkers in their own body, and then record them in a standardized way, so that someone who's trained in RRM can look at those and make sense out of it. So they're tracking their cervical mucus, they're tracking their bleeding patterns, they're tracking sometimes their temperature, and they're recording it. And in this way, we've sort of divided the cycle into 3 phases: the pre-ovulatory phase, the ovulatory phase, and the post-ovulatory phase. And a woman is charting her cycles, learning what her mucus is, when it comes, because the mucus leads up to ovulation. And after ovulation, there is no mucus. So there's a clear delineation there of when ovulation occurs. And this is invaluable for figuring out what's going on with a woman's cycle. So someone who's trained in RRM can look at these charts where the woman has made these biomarker recordings. There's different ones. We don't have to go into all the different ones, but and they can look and they could say, okay, this chart looks like there's patches of mucus instead of a normal mucus cycle. Maybe this woman has PCOS. You could also look and see, well, the second half of the cycle after ovulation is shorter than it should be. So maybe this woman is low in progesterone, which puts her at risk for infertility, miscarriage, and PMS symptoms. You can also see brown spotting, which is common but not normal. And brown spotting can mean lots of things. It can mean a low-grade infection. It can mean an autoimmune disorder, and there's a whole section of medicine that we're just exploring about immunology and things that are going wrong at the implantation site because of a malfunctioning immune system. So brown bleeding can indicate other hormone imbalances as well. And so that's the way you get the pieces together to try and correct and restore. And when you're having a woman recording in real time, this is invaluable for assessing hormones because there's different hormones in the first part of the cycle, the middle of the cycle, and the end of the cycle. And we know in RRM what those hormone levels should be at each place in the cycle. And so when we send a woman in for a hormone evaluation, we are timing that to her cycle, and we can then get the most accurate picture of if those hormones are normal or not. And then, if they're not normal, we can also treat with hormones in a way that restores her physiology, in a way that makes her function like she's supposed to. In other words, if she's low in progesterone, well, then we can time and give her progesterone when the body makes progesterone, which is after ovulation. So we can start it in her chart after she's ovulated and give it to her when she's supposed to get it. And this makes her cycle more like it should be. And that's why we call it restorative reproductive medicine. Now, there's lots of things we look at. And for infertility, we can look at ovulation disorders by doing a series of ultrasounds during the fertile phase and seeing, is she making a big enough follicle? Is that follicle rupturing? And you can think of the follicle as the carrier for the egg. And if she's not making a big enough follicle, then we would do something at the beginning of the cycle to help her make a better follicle. If she's making a big enough follicle but she's not releasing it, we would do something in the middle of the cycle to help her release the follicle. So this is very scientific and very well timed to her cycle and restoring her reproductive health to what it should be if she was not having the problems that she's having. Endometriosis is another area that we excel in because we have specialized training for our surgeons for endometriosis. Endometriosis is when the cells inside the lining of the uterus implant in other places in the pelvis. It could be on the fallopian tubes, it could be on the ovaries, it could be on ligaments, it could be in the bowel, it could be on the bladder. And this can cause extreme pain and debilitating pain, actually, for women, and symptoms of bowel and bladder issues. It's really important to be able to get it all and get it out in a way that doesn't cause more scarring or harming of her fertility. And so we have specialized training for our surgeons that do just that. They remove it all, they find it all, and they do not cause more scarring. And this is really important. And in my practice, when I have someone, it's always an insurance issue, can I send them to the surgeon that I want to send them to that I know is going to do the best job? Now, of course, we look at tubes and uterine anatomy and those things too, but we also really understand that fertility is a vital sign for women. And so if there's something going wrong with their reproductive system, then there's probably something else going wrong with their overall health. And so we look at that person as a woman as a holistic person. And polycystic ovarian syndrome is a perfect example of that. This is something that can cause abnormal bleeding, irregular cycles, hormone imbalances, infertility, miscarriage, but it can also cause diabetes, heart disease, stroke when you get older in life. It can cause high blood pressure. It can cause uterine cancer. So when we are working with someone with PCOS, that's the abbreviation for polycystic ovarian syndrome, we look at them as a holistic person. We help them make lifestyle changes. We help them lose weight. We help them get their sugars balanced. We look at their sleep because those women are at higher risk for sleep apnea. We help them manage stress. So it's a very comprehensive approach where we're looking at women's reproductive systems, but we're also looking at the entire woman because we know they're interrelated. So with this kind of approach, you can't get a better healthcare system for a woman than this holistic approach. And I want to just mention that there are other factors that influence fertility, environmental factors, like you're talking environmental toxins in our water, air, soil, our food additives, our pesticides, herbicides, insecticides, all of those play a role. Before an egg is released, it is exposed for 3 months to whatever that woman is exposed to. And so if she's exposed to a lot of toxins, that egg is going to be exposed to a lot of toxins. So helping her detoxify makes for a healthier woman and also a healthier baby. And so that's part of what we do in our clinic in this combination of functional medicine and RRM medicine. And I thought I would just end with some real examples of how we've helped women, because we've helped hundreds of women in our clinic. There was a 37-year-old female came in. She and her husband had been experiencing infertility for 8 years. They had done all sorts of other things. So we put her through our lifestyle program. We balanced her hormones. She was low on progesterone. We fixed her thyroid. She had endometriosis surgery, and she's due in 1 week after 8 years of infertility. Then we have another patient who's 36. She's had 8 miscarriages. Now, I want to say a word about miscarriages because I think it's very underappreciated in our medical culture and in our culture at large. Women who have miscarriages have real pain and suffering. That's a real loss, and especially if you've had that many. And I think we just have to remember as members of society and as members of the medical community that they're having real pain and real grief, and we have to acknowledge that and validate that for them. Now, this woman also had chronic fatigue, so we found a low-grade infection. We put her on some progesterone. She had endometriosis surgery. We treated her fatigue, and she has a beautiful baby girl now. Then there's another patient of ours that was 23. She came in not cycling at all. She was also not very healthy. She was very tired. She had a lot of gut issues. We put her through our program. We helped her get her cycles back. She cycled then for several years normally, and she just recently had her first baby, no problem. She didn't need any intervention because we restored her fertility when she was younger. And that's the beauty of this. We are restoring women back to where they should be. And so I just want to end by saying I know this is something we can all get behind. Everyone wants great health for women. This is great health for women, and I'm very privileged to be a part of this.
Hi there, I'm Maureen Ferguson, and I come to this roundtable as both a policy advocate for restorative reproductive medicine and also as a patient who has benefited tremendously from this innovative and comprehensive approach to women's health and fertility. You may be familiar with the phrase, shrink it and pink it. Sarah Hill was referring a little bit to this mindset. The Harvard Journal for Advanced Leadership, and I printed this out just for the sake of it, this journal documents the problems that arise when the male body is considered the norm in product design and development. The journal cites examples of this gender bias, such as female surgeons are generally forced to use surgical tools designed for a larger male hand, or car safety testing that for 60 years used only male crash test dummies before finally starting to use female dummies in 2011. As a result, women are more likely to be injured in car crashes. This mentality has certainly affected women's health care, which has a long history of such bias. Women's health care has been given short shrift in a variety of ways, especially in the area of fertility. Research dollars have historically focused primarily on male subjects, as was mentioned, leaving women underdiagnosed and undertreated. It also has left women over-medicated because traditional women's health and fertility care has relied heavily on big pharma Band-Aids and workarounds that circumvent a woman's reproductive system rather than working in harmony with it and doing the work of deeper investigation to find and treat underlying causes of infertility. The doctors we're going to hear more from later today in the roundtable have not fallen into the shrink it and pink it mindset that so much of our healthcare system has relied on. Or in the context of fertility specifically, you might call it suppress it and circumvent it. Doctors who practice restorative reproductive medicine, on the other hand, come with a mindset to diagnose it and treat it. These doctors are incredibly skilled and smart. They think outside the box. They have years of clinical experience with proven success. They have been pioneering innovative approaches that prioritize comprehensive women's health care and successful fertility treatments. Restorative reproductive medicine is effective, affordable, it leads to healthier moms and babies, and it's far preferred by couples, most of whom wish to conceive naturally. As a policy advocate, I love working on an issue that's so unifying. This totally cuts across party lines because women of all political stripes appreciate healthcare that works in harmony with their body and restores health. In fact, I first heard about this approach from my sister, who's a progressive New York City Oberlin graduate whose politics are different from mine. But many years ago, she's the one who gave me this book, Taking Charge of Your Fertility, which has been circulated in her circles for like 20 or 30 years. Nothing new to her. From the patient perspective, I have two quick anecdotes. I had 6 years of secondary infertility in which I couldn't get pregnant, or if I did, I miscarried. My regular OBGYN, who was 10 minutes from my house, did one blood test, told me everything looked fine, shrugged her shoulders, and sent me home with no answers. At that point, I decided I was going to make the 1-hour drive to see a specialist in restorative reproductive medicine. After a deeper dive and more comprehensive testing of my hormone levels on several different days of my cycle, this doctor figured out what I needed. And as my 40th birthday present, I had this baby girl. In the interest of time, I'm going to skip my next anecdote because I know we need to move on. But we need more doctors who are trained to take this more innovative approach to fertility. And again, restorative reproductive medicine is a great tool in the toolbox to treat infertility. It makes all the sense in the world for the government to support RRM research, education, and parity in health insurance coverage. Again, it's effective, at least as effective as the alternative. It's affordable, exponentially less expensive than the alternative. It leads to healthier moms and babies, healthier outcomes for both. And preferred by couples, it's a lot more fun to conceive the original way.
Thank you all so much. So the rest of the event is actually closed to the press. So I thank anyone from the press who came to be here for the Newsmakers Hour. We're going to now set up for the next panel, which is going to be moderated by Emma on body literacy and femtech. So if you're on that panel, please feel free to come up to the stage. Thanks.
Okay, so first we'll start with a question for the group and then jump into individuals. So at its core, as I mentioned, this panel is about how women come to understand their own bodies and how that understanding is either supported or undermined by our healthcare systems, technologies, and cultural messages. So from your individual vantage points, what is the most important thing that women are missing today about their bodies? And what will it take to give that knowledge back to them?
Can you hear me okay? Okay. It's a great question. I think coming from the world that I come from, growing up as a psychiatric patient, where as a teenage girl, I ended up getting sent to a psychiatrist, diagnosed, put on meds that I stayed on for almost a decade and a half. When I look back on what I missed, what I lost connection with in myself, it was this notion that the struggles I was experiencing in mind, body, and spirit were not actually symptoms of an illness. They were signals. They were messages that my body was telling me and my mind was telling me about my relationship to the world around me. And I think with 1 in 4 American women on these drugs, with rates of struggle and despair and suicidal feelings in girls skyrocketing, with more young people than ever before being put on these drugs and being given these diagnoses and being taught to see themselves and their struggles through this medicalized lens. I think for me, it's about what this does is it leads us to lose connection with the wisdom of our pain, our anger, our grief, our anxiety, our sadness, our loneliness. These are important, wise messages, especially for us as girls and women that we're taught in our current social order to basically come to view as problems to be fixed.
I mean, for me, I think one of the biggest misconceptions that people have about the body is kind of the way that we've been treated by the medical system, where it's like the body is treated like something that was designed by an engineer, where you can fix this little part and then nothing else will be affected. You can fix this little part. And rather than understanding our body as being this inherited wisdom that we've inherited for millions of years of the evolutionary process, and that our body has this remarkable ability to stay alive and to heal itself in the absence of a bunch of environmental perturbations. To me, I think that's really something that we're missing because of the sort of medicalization of the human body. And I think understanding that and the deep wisdom of the body and the way that we're feeling, I think is probably something that I think is most important in my opinion.
To Sarah's point, I'm a big fan of the author Wendell Berry. He has an essay called The Body and the Earth that I reread recently, and he says something so brilliant that there's a profound connection between the way we treat the land and the way we treat our bodies. think is a very MAHA sentiment. And we've had a lot of success so far in this administration reclaiming things around agriculture. But I think the commonality is that we forget that things have a nature, that it's not just dumb stuff that we can manipulate at our will and make it do whatever we want. If we just pull this lever and this lever and this lever, then we can always control the outcome. And that isn't how nature works. It's not how the land works, and it's also not how our bodies work. And I think most of women's health has spun out in the context of this forgetfulness of our nature. And if you don't understand how your body works in a state of health, then you can't have informed consent over any healthcare decision that you make. But most women don't know what they don't know about their own bodies. And so that's how I would begin to answer your excellent question, Emma.
So I think in this question, I think of the entry point into healthcare for men and women, but for women in particular, it's usually a period problem. So I'm sure like many women out there, oftentimes like we have a story, a personal story, and so many women become passionate about this area of women's health and this movement because of a personal story. And I'm no different. You know, I was an athlete. I lost my periods in college. They became very irregular. I went to an OBGYN, and the only thing I was offered was birth control pills. Not even understanding my own body at that point, I took them. Within 2 months, I had gained 10 to 15 pounds, had acne all over my face, and I thought, what the heck just happened? You know, and I didn't even understand how my body worked at that point. I didn't understand how my body worked until I was through nurse practitioner school. And I think sitting with many women and their daughters in my patient office, I feel this thing happens over and over again. I have a mom, I'm looking at the daughter, I'm starting to talk about her periods, and I'm looking at the mom and I'm wondering, does she even know how her own body works? Was she on birth control for the last 15 to 25 years? And I start to talk to her, a young female, about her menstrual cycles and whether she knows anything else besides that she bleeds once a month. That there is this main event of her cycle that she needs to be aware of, the main pivotal event, hormonal event of her body that gives her so much more information. And most times, the mother sitting next to her actually had never heard that information before as well. And so you're educating not only the future generation, but the previous generation, and I'm sure many of you know this, when you educate the previous generation, what are they at that point? They're frustrated and angry because they have been in a system that has told them over and over again that the only thing that you need is really to suppress a part of your endocrine system that somehow you need to risk mitigate. And that's the second entry point into healthcare many times is sex education, which really only focuses on risk mitigation. Can we prevent you from getting pregnant and prevent you from getting a sexually transmitted infection? That's the entry point for people understanding their hormones, but not really. Those people never understand their bodies. They're really just told there's something they constantly need to risk mitigate, this part of their endocrine system. And it's a really poor way to treat the female's body and men's bodies for that matter. And again, this is why I'm super passionate about educating people, because this is where all those videos on TikTok can really help us, because my patients come in and say, hey, I saw that on TikTok and I want to learn more. Awesome. Let's start educating about your body and your hormones and how this all works.
I come to this from a little bit of a different perspective. My background's not in the medical field, but in the technology policy space. And so what I would say that I think both women and men need to realize is that their use of internet technology in particular can affect fertility. And so my research has focused on actually the impact of pornography use and the effect that that has on fertility. That not only is internet pornography replacing in-person sexual activity, we've just seen drastic decreases over the last several years in in-person sexual activity, but also pornography warps and changes our desires, that people who become more frequent users of pornography actually prefer pornography than to sex with a real person. And also we have seen spiking rates of erectile dysfunction in young men attributed to pornography. So one 2-year longitudinal study of 16 to 21-year-old men found that 45% of them struggled with erectile dysfunction. And even the advertisements will tell you this. If you watch television programming, they're advertising erectile dysfunction drugs, not to elderly men, but to young men, that this is now a common problem that our men are facing. And so this is both an issue for women and men, but just the impact of pornography and also the internet more generally, that there's been studies done that the diffusion of mass media in a culture reduces fertility rates. And one study done back in 1997 found that the greatest national predictor of fertility was the amount of televisions per capita, which I just think is fascinating, that was the predictor of the fertility rates in a country more than any other factor, because what is that mass media replacing? And Jean Twenge, who is a sociology professor, she writes on these trends in generations, and she has noted that the rise of internet technologies, not just pornography, but smartphones, social media, binge watching Netflix, replaces that time in the evening that would typically have been spent engaging in sexual activity. And so the kind of drain on our attention and then our attachment in real life to real people, I think is an underappreciated factor contributing to the fertility crisis that we're facing. And so that's what I would add to the conversation.
That's fantastic. Thank you all. So Katie, moving to you, I would love if you would talk to us a little bit about what body literacy is. Why is it such a powerful shift for women? And also if you could just address in the midst of that how accessible it is. There's oftentimes this notion that cycle tracking, that body literacy is for a certain class of person or a certain person who's engaged, who wants to be deeply aware, right? And so I would love to hear you speak, just on what body literacy is and how it applies beyond just your typical demographic.
Beautiful, great question, Emma. So yes, always important to define terms. So it's kind of obvious, right? If literacy is the ability to decode signs and symbols in language, then body literacy is the ability to understand and interpret the signs that your female body is giving you every day. Some brilliant woman in Canada just wrote a dissertation on body literacy. She says, our bodies are communicating to us as women through our cycles. And our ability to understand this communication is called body literacy. Really simple. A little history on the term. The woman, Laura Werschler, in 2005 was the executive director for Planned Parenthood of Alberta. And she's credited as introducing this term for the first time in the literature. She said, learning to read and understand the language of the body, learning to observe, chart, and interpret an ovulatory menstrual cycle. And I appreciate that she said ovulatory, right? Because women know they have a red flow, but most women are not taught about their white flow, right? And so we want to position ovulation as the main event of the cycle. We want women to understand that this is the sign of health, that is the fifth vital sign that we're looking for. When I talk about body literacy for adolescents, I think baseline, we want every woman to know that she's a cyclic being, that it is logically incoherent to expect that she feel the same every day of her cycle. We want her to understand what's happening hormonally in the 4 phases of her cycle, how she can expect to feel differently at different times as she moves through those phases. We want her to understand her biomarkers. We want her to be able to understand how her basal body temperature is going to rise in that second half of the cycle and why. We want her to have knowledge on her hormonal ebb and flow and how she could track that with urinary hormones and emerging femtech should she desire. And then the most available, no technology needed biomarker is of course her white flow, her cervical fluid. We really want her to see how her hormonal health affects her overall health. There is a common myth that women can conceive literally any time. This is not true. We can only conceive during a very narrow window, and most women are unaware of this fact. It's only right around that time of ovulation. We want every woman to know the basic parameters of health around a menstrual cycle. so that she knows when she's seeing something that's outside of a healthy cycle so that she can seek help. And then we want her to have informed consent about what to do about that. We want her to know she has options. She can choose symptom management through hormonal contraception, and she can also choose to pursue the root cause of hormonal distress, and we want her to have access to that kind of care. And I mean, to your point, Emma, this isn't just like secret Gnostic knowledge that only bougie, white, middle-class women get to know. This should be knowledge that is available to all women, full stop. And we know where there is greater health illiteracy, there are greater disparities, especially around chronic diseases. And this is true at a high level, and it's especially true when we talk about body illiteracy and women's health issues. And I think we could really put a dent in erasing those disparities in health if we spent more time focusing on under-resourced populations and building this basic knowledge that, as my colleague Grace said, is every woman's birthright.
That's wonderful, Katie. And as someone who's looked through Elevate and other programs that you've put together, I wish I had had that when I was going through middle and high school. But this brings me, Sarah, to you. This Is Your Brain on Birth Control was like this secret knowledge that all of our friends in Gen Z passed around when it came out. And it started out as whispers. We were like, did you know that you could criticize birth control? And this woman has the studies to prove it. And all of a sudden we were like, this is amazing. And it sort of like justified a lot of the like intuitions we had deep down, but didn't have the language to put to it. And that's what I love so much about what all of you are doing, but particularly your work, Sarah, really putting language to that. So I was wondering if you could speak about the research that you found in This Is Your Brain on Birth Control and the surprising ways that the pill influences who a woman is, how she views herself, her identity, who she's attracted to, and sort of like the cultural impact that that's had on our society today.
Sure, I'd love to. Thank you for the wonderful compliments, and then also a really great question. So I think the most important thing that I start to address with This Is Your Brain on Birth Control is just this idea that we are our hormones. You know, and we tend to think about our hormones as something that happens to us, right? Like, oh, you know, I got this pimple as my hormones, or, during puberty I feel terrible as my hormones. But our hormones are a part of the signaling machinery that our brain uses to create the experience of being the person we are, right? And when our hormones change, that means that it changes the version of ourselves that our brain creates. And what this means, again, just to sort of build on this, is that when you take a naturally cycling woman, and for a naturally cycling woman, you get this beautiful ebb and flow between women's two primary sex hormones, which is estrogen, which rises and peaks in the first half of the menstrual cycle, right, peaking right prior to ovulation and then falling. And then in the second half of the cycle, you get the rise of this other second primary sex hormone, progesterone, right? And with these two, the waxing and waning of these two hormones, women's experiences change, right? And so we know from decades of research now in neuroendocrinology that when estrogen is high and rising in the cycle, that women have more energy, they have higher libido, so their sexual desire increases, their sexual behavior tends to increase, they tend to look, sound, and smell sexier to men at this time relative to other points in the cycle. They walk faster, right? They enjoy music more. I mean, their brain is like primed for the world and like taking in information. The spines on your like you get these dendritic spines on your neurons, they start to sprout in response to estrogen. And you're your most sort of responsive, sexy version of yourself that you are across the cycle. That hormone begins to fall, and then progesterone rises, and this hormone makes you a little sleepier, it makes you hungrier, it makes your threat detector increase, which is why women get a little bit more emotional during this time, because it takes less scary information for their alarm bells to sound, right? And so you get these changes where your body's preparing itself for pregnancy, right? And there's this beautiful move between hormones that are designed to coordinate sex and conception, which is estrogen, and then this hormone that's designed for implantation and pregnancy, which is progesterone. And so it shifts who a woman is as she's going between these two states, where her body's optimized for sex and then optimized for pregnancy, and optimized for sex, and optimized for pregnancy. And you take hormonal birth control pills, and all of that gets shut down, right? And so a woman is no longer ovulating when you take hormonal birth control. It tells your brain to not stimulate the ovaries to produce an egg, which is how we produce all of our sex hormones, is through the act of ovulation. And so it prevents all of that from happening and gives you the same daily dose of a relatively low level of estrogen and a relatively high level of synthetic progesterone, or what's known as a progestin. And getting this same daily message, it's going to change the version of yourself that your brain creates, right? You're no longer waxing and waning between a version of you that's optimized for sex and a version of you that's optimized for pregnancy. Instead, you're this constant version of somebody who's not quite human, right? Where you have relatively low levels of estrogen, which is why we find, for example, that women who take hormonal birth control tend to have lower libido relative to naturally cycling women, particularly naturally cycling women in the estrogenic phase of the cycle. But you also tend to get changes even in things like attraction, right? Because we also know, for example, from decades of research, that when estrogen is high across the cycle, that women are most sort of highly attuned to cues related to testosterone in potential partners. And so we know that when women are at an estrogenic part in their cycle, they have a heightened preference for masculinized male faces, voices, and behaviors, right? And so when you suppress that, what you find is that that nudges women, not so much like in terms of a major mate choice preference, but instead they're not emphasizing those qualities in their partner choice, and instead are focusing on other qualities, right, which are also important. So things, for example, like provisioning ability and parenting quality, some of those things that might be more important in the context of pregnancy, right? And so what we find is that taking the birth control pill, in addition to having some of the side effects that all of us know about, right? The possibility of a stroke, or a possibility of, a heart attack, that it can also potentially nudge your partner preferences in ways that are somewhat different than what they would be when you're naturally cycling. We know also that it's associated with an increased risk of developing mental health disorders, particularly in teenagers whose brains aren't done developing. And this is one thing that's almost never talked about when we're talking about the birth control pill, and that is that if you take it prior to your brain being done developing, so if you take it during adolescence, and usually in psychology or in the world of neuroscience, we define adolescence as any time before age 19. It's like 12 to 19 is generally the window that we consider adolescence. Your brain is still developing, right? And guess who coordinates pubertal brain development in the body? It's your sex hormones, right? So what happens when we suppress women's sex hormones during the pubertal transition and don't allow them to do the things that they're normally supposed to be doing during brain development? And the answer to that question is we don't know, because nobody is studying it, right? So we have this generation of a natural experiment on women where we don't know how it's changing brain development. Women are being put on the birth control pill as teenagers for things that are as sort of minor as irregular cycles, right? And this is something that can potentially have lasting impact on their brain. And until we have the research to know whether or not this matters, right? Because there's no way it doesn't affect brain development. Like, there's no universe in which this could possibly be possible, given the way that hormones orchestrate brain developmental changes during the pubertal transition. The thing we don't know is whether it matters, right? And how much it matters. And so these are things that we critically need to know, right? But all of these are sort of the hidden story behind hormonal birth control and its sweeping impact on the way that women think and feel and experience the world. So, thank you.
Incredible. So Teresa, going to you. So you host the podcast, The Hormone Genius. You're meeting with patients and working with women. So I would love to hear some of the aha moment stories where women or guests of yours on the show are really, having those moments like many of us just had listening to Sarah, where they're like, wow, I had no idea that's what was going on. So kicking it over to you.
Yeah, I mean, actually listening to Sarah, I'm like, I got a story. I got a story for that. I got a story for that. I mean, and this is one story that I'll tell you, and it makes me wonder, and if you have any, and maybe you will do future research on this, is I had a patient one time who had taken birth control since she was like 15 or 16, took it until she was 30. She hadn't met the person that she would eventually want to have children with. But until she got off birth control, she had never thought about the way she felt about children. And so she had always wondered why she didn't feel this kind of desire for babies. Like she would see a baby and she'd be like, oh yeah, that's cute, but I don't know if I want one or not. And it wasn't until she came off birth control that she all of a sudden looked at a baby and thought, I want that. And it really, for me, kind of had this like aha moment of being like, what are we doing from a fertility standpoint, a cultural level, population level standpoint, when we suppress the main event of the cycle, which is our natural evolutionary desire to procreate new human beings? And I think these are the big, giant questions that we as a society really need to start talking about, because we're declining our populations, but we're suppressing a desire for the nature to want to have children. So that's one story that I was thinking about in relation to it. I'll give you another story. And this one of a young woman who went to her doctor, very similar story to many women who had a period problem. And she was put on birth control, again, around the age of 15. And at that point, she started to feel crippling anxiety. And of course, she went back to the doctor and said, I'm experiencing this crippling anxiety. She's like, I'm wondering if it's related to the medication I'm taking. And of course, what do you think the doctor said? It couldn't be related to your birth control. But since you're feeling that, why don't we just switch the birth control that you're on? I can't tell you, I know there's a statistic for this that Jamie, my Hormone Genius co-host, talks about. I think it's like women on average change their birth control like 5 different times in a certain amount of year period. And so she went back to her doctor, I think like at least 5 times. She had been put on different birth control over and over again, still experiencing crippling anxiety and mental health issues. Somehow she found my podcast, started listening to it, and what did she hear? Someone validate the fact that her mental health concerns could be related to the medication that she was taking. And so she came in, and I'll never forget it, she was 20-something at the time. So this is, again, a girl suffering from the age of 15, that many years, and she had written like a whole blog post that she titled #NuffSaid. And it was all about her just frustration with the fact, I think in part of it, she said, man, I could have walked in there, my arm could have been cut off, and they would have been like, well, it's not your birth control, that's for sure. Like everything was about this idea that like, you can't possibly be feeling what you're feeling in relationship to the medication that I think was right for you. And this is what I think we refer to as gaslit or gaslighting, right?
Oh yeah.
Yes. And that's exactly, so she's sitting in my office shaking practically, still on birth control, by the way. She hadn't come off of it. Because what weirdly enough is women almost need permission to, right? Because this is the power frame that we have in medicine. I am the doctor, I am the professional, I tell you what to take, you believe me, and no matter what, this is the game we play, right? And so she hadn't stopped it. And she's like, could this be the answer? And she's heard my podcast, yes, it could be the answer. And at the end of the appointment, do you think I can stop this? And I've had this conversation, many, many times with women her age. Absolutely. You have autonomy over your own body. You are an advocate for your own health. You deserve informed consent and to know that these side effects are a part of these medications. Absolutely. And so 6 months later, she came back to see me. And I was kind of nervous because I always tell people, I don't know what's going to happen. I know one thing, you'll get to know the real hormonal you for the very first time. How exciting is that? But I don't know what that hormonal you looks like. It could be a little scary. It could be a totally bumpy road. So I'm just forewarning you, I don't know. But, we got to get to the point of really identifying you and the problems and all the things at some point, right? So it's an exciting thing for women to experience that. So 6 months later, she came back to see me, and I said, how is it going? And she was like, it is the best decision I've ever made in my life. I finally feel like a normal human being again. And she was so happy, and every time I've seen her, she's like, yeah, I'm still doing amazing. But again, all of those years of suffering, unnecessarily, when we all know birth control increases the risk of anxiety and depression. But she was told over and over again, it can't be that. I have one more story, and I'll finish it. I had a woman that came to see me after having 5 children, and she had seen her OBGYN because she went in for complaints, super duper heavy periods. She felt terrible. She had, hair loss, fatigue, kind of all the typical symptoms. And she asked her doctor to test her hormones. Well, you, I'm sure, can imagine how that went. Test your hormones. What's the point of testing your hormones, right? So the doctor kept pushing back. No, I really think this is related to my hormones. She's like, of course, you have 5 kids. You're tired. You're getting older, all the things. I really think this is related to my hormones. Can you please test my hormones? I mean, this went back and forth, this woman said, multiple times between her pressuring for it and the doctor pushing back. Finally, the doctor got upset and said, your menstrual cycle has nothing to do with your hormones. I'm not joking. What, 9 years of medical school to make that statement? To make that statement. Okay, she comes in, same complaints, tells me the story. Guys, if you would have just looked at the woman, she had a massive goiter. A massive goiter. Not only that, it was asymmetric. Had the doctor just looked at her, she could have made the diagnosis practically by just looking at her and listening to her symptoms. A simple blood test revealed she had massive hypothyroidism and a thyroid tumor that needed to be removed. I mean, this is over and over the type of health care women are getting. It's at the point where OBGYNs are kind of like, I just deliver babies. I mean, and let's not get into menopause and that disaster, but at this point, it's just kind of like, I'm a one-trick pony. I deliver babies. I don't do anything else. I don't know how to test your hormones. And frankly, they're right. They don't. And I don't think they should until they know how. But it's really like women do not deserve this type of health care. And this is where we can all now move to make a difference. Yes.
Wow. Those are incredible. Thank you. So, Laura, shifting to you, we've talked a lot about birth control and body literacy at this point, but you have an incredible background in psychiatric drugs and antidepressants. And so what I would love for you to speak to is you've talked about before how psychiatric drugs can disrupt a woman's connection to her cycle, to her libido, and even to her instincts. So I was wondering if you could explain how these drugs affect body awareness and what women often realize only after they start taking these drugs.
That's a great question, yeah. And we can't talk about body literacy without talking about psychiatric drugs. And for anyone not familiar, these are drugs marketed as antidepressants, anti-anxiety drugs, mood stabilizers, antipsychotics, sleep aids, ADHD drugs. And with, as I said before, with 1 in 4 adult women on these drugs, with teenage girls between 2016 and 2022, rates of antidepressant use shot up 66%. This is an epidemic issue here. And we're told this mythology that when you're struggling, it's because you have, when you're having a mental and emotional challenge of some kind, it's because you have a chemical imbalance in your brain. Here's a pill that's going to treat that chemical imbalance like a magic bullet. It's an enticing story. I bought into it eventually myself because I was desperate for relief and I wanted a clear answer that seemed to have a clear solution. But in retrospect, of course, when I actually began to educate myself after being on these drugs for a decade and a half, I realized, this idea that happy hormones are in your brain and you can just target them with a pill is so unscientific, so absurd. And we've known this for decades, that these reductionist stories are basically BS, and yet it's just common in the culture to believe in this idea of chemical imbalances. These drugs act on, especially the serotonin system, the dopamine system, the norepinephrine system, GABA. These are not just about your emotions. They control basic body function, metabolic function, digestive function. Every facet of your being as a human is shaped by these hormones that psychiatric drugs interfere with. And so I think, because these meds have become so normalized and ubiquitous in our culture, as has taking any pharmaceutical, ask your doctor, the soporific voice, reading the list of side effects at the end of the commercial that you don't even pay attention to because it's so pretty and nice sounding. We are so desensitized to just how profoundly powerful these psychoactive chemicals are. Sarah, one thing I'd love to chat more about with you is that these drugs, when I looked at the FDA website after I began questioning these pills I'd been on through the most formative years of my life, I was shocked to learn that these drugs are studied on the average, on the basis of studies that last 6 to 8 weeks, yet most of us go on to take them for years, years, with zero evidence base for their safety and effectiveness. These drugs have there's no research in polypharmacy. All of these things I had just taken for granted because if my doctor was putting me on these things, then they must be studied and safe and effective. We as women, as girls and women, men and boys too, have to take this power back into our own hands and recognize that the decision to start one of these pills and potentially stay on it for the long term brings so many consequences. Perhaps one of the most important ones being, because these drugs are only looked at for short-term use, what none of us are being told is that when you take them for long periods of time, you become physically dependent on them. And that means that if you try to stop your drug down the line and you feel horrible, you're going to be told, oh, you're having a relapse, quote unquote, a relapse of your depression or your anxiety. See, this is why you need your medication. And then you think to yourself, oh my gosh, yeah, I don't like how I feel when I don't take my meds, so I must need to stay on it indefinitely. No one tells us that you are actually in acute withdrawal. These struggles that you're having, which might mimic the diagnoses themselves, are actually withdrawal symptoms. And this is especially important for us as girls and women. When we are put on these drugs young, we are not being told, by the way, if you stay on these drugs to your 20s, one day, if you eventually decide you want to have kids, you might have a hell of a time getting off of these. You may need years, literally years, to taper off of them in order to minimize withdrawal symptoms. So make sure you factor that in to your family planning. None of us are being told this, and I cannot tell you how many women I hear from who have realized this, and they're older, they want to have kids, and they feel trapped because every time they've tried to stop their antidepressant, they feel horrible. Their doctor's telling them, it's irresponsible of you to not take your medication while you're pregnant. That will harm your baby because a depressed mom is, going to lead to problems for the baby. But women are not being told these drugs actually have serious effects on baby in utero. They're higher, and during birth, there are higher rates of postpartum hemorrhaging, preeclampsia, the drug effects on the babies themselves, brain development, all of these things. We are not being told this. I was not told this, and I feel so lucky that I had the resources to get myself out of this mess in my late 20s. So many girls and women don't, and so I think when we talk about body literacy, and to speak to your question too, having grown up on these drugs, and now that I've been off of them for 15 years, and I was on a whole slew of them, I cannot tell you how every single facet of who I was altered by them. I can only see this in retrospect, and that's the bind. When you're on them, you don't see what you don't know. You don't know who you would be had you gone down a different path and not taken these meds. I only see now in hindsight so much of what I thought were concomitant health issues, IBS and chronic headaches and joint pain and sleep problems, all these things. Once I got off these meds and took years to heal from them, years. And I looked back and I said, oh my gosh, so many of the things that I thought were me, and so many of my personality traits and my behaviors and my thought patterns, it was the meds. And there's no space for this conversation right now within the conventional mental health system. And I don't blame doctors and therapists. They're doing the best they can with the information they have. But we have to kind of take this lens off of our eyes of just, when you're struggling, it's because you have a chemical imbalance, it's an illness, let's treat it with pills. Once we remove this medicalized lens and we actually recognize these emotional struggles, as I said earlier, as responses to maybe something is happening in our bodies, but it's not faulty chemistry in our brains, responses to our lives, then we don't need to see just this one solution of pills. We can step back and reflect and think about, what is my pain telling me? What do I need to change in my life? Because the consequences here for a lifetime, decades of these meds are so profound, and you can't be literate in your own body when you're under the influence of these medications.
That's so well said. And to shift a little bit from psychiatric drugs to another very powerful drug being pornography and digital technology. Oftentimes conversations around pornography deal with the morality of it or free speech rights, or the right for kids to. Shout out to Paxton, which was just handed down today. Claire is very gracious sharing her time with us in the midst of, I'm sure, a crazy media day. But Claire, one of the things that I love that you have talked about is how our tech-driven culture sells us a friction-free life, often at the expense of embodiment, relationships, reproduction, and this full feeling of being human, as many of you have said. So I was wondering if you could help us chart the path out. So what does it look like to reintroduce meaning and limits and even reverence into our conversations about the body and about sex?
I'm so glad you asked. Yeah, and I will say, just even hearing all these talk about the brain and the impact is, I think there are clear studies showing that pornography and social media and smartphone use impact our brains in really negative ways. That in the case of pornography, actually there are neuroplastic changes that then reduce sexual arousal with a real person. So that's changing it not just at a biological level, but at the brain chemistry level. And I've also done a lot of research to try to understand more about this neurotransmitter dopamine, because part of what makes pornography, smartphone, social media so addictive is we get this little hit of dopamine, this burst of pleasure in the brain each time we get a new notification or a new like. And the problem is, though, that we get dopamine, but we don't get oxytocin. So our kids, especially who are growing up online today, are in this oxytocin desert, because oxytocin only comes from real life relationships and friendships. It comes from in-person interaction, eye contact, physical touch, and it's what bonds a mother with their child, and husband and wife and friends. And so not only are our lives moving online and are we struggling with dopamine addiction and these changes in our brain, but our bodies and brains are also being deprived of this critical hormone, oxytocin, that actually we need to form real life relationships, bonds of trust with a real person. And how can that not have an impact on fertility? And so I think just zooming out too, just at a cultural level, the widespread adoption, particularly for children. And so what Emma was just alluding to is this major Supreme Court case that came out today, because my policy work has really focused on protecting children and their brain development. I really appreciated you mentioning the brain is not fully developed until adulthood. And so just the impact, especially on young brains, of exposure to these things, and that we are just facing an online pornography epidemic. Children are not looking for this. They are stumbling across it on social media. One survey of high school seniors found that 78% of them consume pornography on a regular basis. And then other studies have shown that of the children and adolescents who are accessing pornography, 58% was accidental. They didn't mean to find it. They stumbled across a link. And the thing is, children's brains are curious, and so they don't even realize, because of the algorithm-driven nature of social media, of pornography websites, they're quickly sucked down these really dangerous rabbit holes. And so on the policy level, a pathway out that I've advocated for, and that now 24 states have passed into law, are just age restrictions for pornography websites. That there's no reason a child should be able to click through to Pornhub inside of the Snapchat app in just 5 clicks without ever leaving Snapchat. A parent would never know, because they don't have to verify that they're an adult to click through to Pornhub and all of its terrible, obscene content. And so it was a huge victory today for those who have not been following the Supreme Court, which is fine if you're not, that they upheld Texas's age verification law for porn websites. 6-3 decision upheld that law. And I can't emphasize enough how much of a landmark decision this is, and what the court really recognized was the change in technology the last 20 years that made them revisit that past precedent, because of how ubiquitous and easy it is for kids to access, and how difficult it is for parents to effectively filter children's devices. So parents critically need backup. I'm so excited to see this law be upheld. I hope that we get this at a nationwide level to just really back parents up. But on a more family level, this is what my work has focused on. I just brought a copy to hold up. So this is what my book, The Tech Exit, A Practical Guide to Freeing Kids and Teens from Smartphones, really focuses on, is how can parents successfully delay, resist smartphones and social media during childhood successfully, like even through the teen years. And so I interviewed just dozens of families who have actually done this, because the argument I kept getting in my policy work, all the harms I had researched convinced me that a smartphone-free childhood was necessary, but no parent believed that it was possible. They all say smartphones are inevitable for our children. There's no way I can't give it to them. And so this book really set out to prove to myself, first and foremost, I have young children, and this is what I aspire to do for them. But I wanted to know, if parents have done this, how have they done this? And so this book is really the result of that, a step-by-step plan for parents to first detox from these technologies if they've already given them. We were just mentioning, like, detoxing from these psychiatric drugs, like there are actual withdrawal symptoms taking these interactive screens away from kids because of the effects on the brain and the body, but that it can be done. Like, detoxing works, and the families I've interviewed just say that this was the best decision they made. They only wish they had done it sooner, and then how to keep going over the long term. And so this is a really practical roadmap for parents, as well as what schools and policymakers can do to back parents up. So I have copies of these postcards where you can get more information and access how to order the book on this resource table over here. So please grab one, and please also grab several and spread the word to your friends, because I will just say the epidemic that I see from smartphones, social media, and pornography, it's not just an individual level. Like, there are real individual harms to children, but it's at a societal level. And I really fear what this means for the future of our country and the culture, the impact on fertility, the impact on relationship formation, on health, if we continue to allow our children to grow up on these extremely addictive and mind and body warping technologies. So anyway, I would encourage you to pick up a copy and then just celebrate the victory that we had today.
My first official employer, Brad Wilcox with the Institute for Family Studies, once quipped that he spent the first half of his career trying to convince people not to have sex and get pregnant outside of marriage. And he's spending the second half of his career trying to convince people to just have sex and get married, because it's such an amazing thing. And like, if the kids would just get together, we might save the country. But at the encouragement of Claire Morell's work and so many of our friends in this space, my husband and I have ordered dumb phones, purchased a Garmin off Facebook Marketplace, and we're starting a 30-day fast from all screens, except for my laptop, because the Heritage Foundation still requires that I work. But we believe that creating that kind of life for our children starts with creating it in the home and the relationship that we have with one another. But on that note, I want to thank all of the wonderful panelists here for sharing your wisdom and your expertise today. So for this second panel on lifestyle and metabolic health, our goal is to have a conversation about how nutrition, lifestyle, and metabolic health intersect to support fertility and empower women with practical, personalized care. And so to open up this discussion, I have a question that I would love to hear each of you speak into. So I was wondering if you could speak from your own areas of expertise. What are some of the early clinical or subclinical signs of metabolic dysfunction that are most predictive of fertility challenges? And how should we be proactively screening for them more effectively across multiple specialties?
Hi, everyone. I'm Dr. Andrea Salcedo. I'm an OBGYN, and I have a confession. I check hormones. I'm so glad to be here. Thank you for the Bazuski Group and also MAHA Institute for inviting me. I'm really excited to be here. This is a huge question, and it's a big part of what I do. It came from a personal experience myself being diagnosed with gestational diabetes, but also endometriosis and struggling with infertility. I totally didn't fit the bill of who would get gestational diabetes. And so during one of my pregnancies, I just was really frustrated with my own standard of care, with the advice that I was giving other patients, the advice that I was actually told, to have a certain number of carbohydrates and continue to have a healthy pregnancy, but I just couldn't. Any carbs I had, my sugars were like in the 200s. And so when I finally delivered, probably after being in therapeutic ketosis for most of my pregnancy, I had a wonderful, healthy baby, and I started diving into the literature of metabolic health and insulin resistance and how it affects gynecologic and obstetrical care. And I started learning about how end organ damage, right? Do we know what this is? End organ damage is the solid organ inflammation that organs receive whenever they're a recipient of cardiovascular disease risk and inflammation. So think diabetic retinopathy, think cardiac disease, think asthma, think NAFLD or fatty liver, right? All of these things are actual inflammation where the organ is receiving inflammation and having problems. Well, why not the uterus? Why isn't the uterus considered an end organ as well? And that's actually the huge focus of my research. And so what I do is look at how is it that the uterus is receiving the same inflammatory factors that all the other organs are, just like the smooth muscles of the veins and arteries? Could it be that uterine fibroids are actually atherosclerosis of the uterus? And so that's a huge part of what I do. I actually published a study just 2 weeks ago, which is actually the first study that was ever published that looked at insulin resistance in abnormal uterine bleeding as a whole. And so when I actually look at your question, I think, what are the inflammatory factors? Are they deficient in vitamin A? Are they not having too many carbohydrates, which causes elevations in insulin, which cause damage to the blood vessels? And so I really hone in on that approach. And really, that umbrella approach really helps guide treatment for pretty much every gynecologic disease. Thank you.
I'm Victoria. And yeah, so I'll just start off with the fact that 93% of Americans have at least some marker of metabolic dysfunction going on. So if you have a patient coming to you, you can kind of make a good guess before even knowing anything about them, they might have some metabolic dysfunction going on. So I'll just say that. But of course, we want to look more critically at what's really going on in them personally. But yeah, I think that every woman, honestly, anyone at all going to a doctor should have a fasting blood sugar and a fasting insulin tested. I mean, just right off the bat. Now, even that, though, doesn't always pick up on everything because it is just one point in time, and they could be having other, blood sugar dysregulation throughout the day, but that's a really great way to do it. And of course, if, I've had some clients who are working with really great doctors, and if they're referring, and they'll come in with an oral glucose tolerance test done, and that's like a, over a 2 to 3 hour window of, after drinking the gross sugar drink that they have, that can show us a lot of information too. So there's some definitive things that can tell us, again, even just talking about blood sugar, blood sugar is a primary thing of focus when it comes to metabolic dysfunction. So there's just some good ways. I would say additionally though too, a really good clinician, or when I work with my clients, if we have a really good thorough discussion with someone and really start to talk about what their day is like, how their energy ebbs and flows throughout the day. What is their dietary pattern currently like, and what has it been in the past? That's very important. What has their stress been like? They might say, oh, it's fine now. What was it like a couple years ago? Tell me about your stress history. All of a sudden, oh my gosh, I used to have this crazy job for many years, and it's better now, but actually all my symptoms began right after that, right? So we can start to, I think, outside of just testing, but actually just having really good thorough health history discussion about what's been going on. And then again, understanding what their symptoms are ebbing and flowing throughout the day. Is their energy crashing at different times? Are they having crazy cravings? Are they actually having blunted appetite in the morning sometimes? And these are all things that can point us to some blood sugar dysfunction, cortisol, which can be wrapped up in that. And I would say additionally too, then there are additional tests that I love to run with my clients. I'm sure Ginny probably as well. Additional nutrient testing. That's something that can be done just through regular blood work, that we can just do it more of a comprehensive panel. There's a lot of information we can glean from that. Again, going beyond just, I don't want to get too clinical here, but going beyond just a comprehensive metabolic panel or a CBC, there's a couple other things we can test just from regular blood work, and insurance can potentially cover it too. That can give us a lot of answers. And then additionally, a little bit deeper dive and more advanced functional lab testing, a little bit more, up and coming, hair mineral testing. I know it's maybe controversial or something, but there's a lot of information we can actually get from that too, because nutrients really are so much part of this as well. You can bet that if someone is already has some metabolic dysfunction going on, they're going to be nutrient, I would say insufficient. Maybe they're not clinically deficient yet, but they are going to have nutrient insufficiencies by virtue of that's what got them there, but also as the process of metabolic dysfunction furthered, it actually causes more nutrient depletion as well. So it's a lot of things that we would want to look at there.
Yeah, I think what I'd love to expand more upon is lab testing, because what I think is such a disservice going on in the medical community is that these are such cheap, easy labs to run, and they are not being run. A fasting insulin is $5 out of pocket, and yet barely any doctors that I see are running it. And while I was diving into the research of insulin resistance, a very well-trusted, the HOMA-IR, which is the homeostatic model assessment of insulin resistant, it is so easy. You can plug a fasting glucose and a fasting insulin into your computer. You don't need to know the fancy calculation, and it's actually really not that fancy. You could really do it on a regular calculator, but, and it is a very good predictor of insulin resistant, and yet we are not doing this very basic marker. Elevated triglycerides are another really big marker, over 90 for elevated triglycerides. And again, most people are getting this run on an annual test, and yet it is not being flagged, it is not being mentioned. And these are not, again, these are not expensive. The world of functional medicine is extremely expensive. Yet when it comes to metabolic health, we do not need expensive markers to determine metabolic dysfunction. So that is, I think, a great injustice being done. And then secondly, when it kind of comes to specific symptoms that you asked about, how many of us are experiencing chronic fatigue, cravings, nighttime wakings? These are very vague and general symptoms that are early signs of metabolic dysfunction. So, and then of course, then there are some more clinical signs like frequent thirst and urination, dark patches on the skin tags. Sometimes those are more of like later insulin resistance, but some of those more early, like chronic fatigue, cravings is, what I see. And then, like I said, most of these can be picked up if you do a fasting insulin, fasting glucose, and then put it into that calculator and look at those triglycerides. I see that missed in my practice 90% of the time. And again, it wasn't that expensive to run in the first place. So that's where we need to start, in my opinion.
So I would, agree with everything that everyone said. But I also think we need to define metabolic dysfunction and really understand what we're talking about here. Metabolic dysfunction, I think, is a big catchword now. When I look at a patient, even if she's been diagnosed with PCOS, I usually tell her, I don't know if you have PCOS, but I'm not going to assume you do. I'm going to assume it could be something else, because I would suggest that half of the patients that come in to see me that are diagnosed with PCOS don't actually have PCOS. They have lifestyle and mainly diet problems. And so I look at them and I'm like, some of them would say they're a little bit overweight unless they have a lot of central obesity. I usually don't, think the weight's a huge problem. It'd be great to have inflammatory markers. It would be great to have fasting insulin. It would be great to have, obviously, glucose tolerance test, the lipids, the triglycerides. I don't get all of those. I will recommend some of them. But just talking to women and hearing the symptoms you were talking about is very telling. Energy is one of the biggest ones. Low energy levels, but that doesn't mean they have this metabolic dysfunction that's longitudinal. It could be something that's easily corrected through appropriate nutritional intake and getting out the foods in their diets, which a lot of women that I see are not eating because they know this, but not everyone, to take out those industrial seed oils, those fried foods, those fast foods. And once we do these things, within a month, they usually feel, and get appropriate nutritional supplementation as needed. You can see signs and symptoms of nutritional shortfalls. In people, you can request labs, you can ask for things like zinc or iron levels. But for me, vitamin A deficiency is probably the main nutrient deficiency I see across the board in fertility. And you see it too?
100%.
100%. This is really interesting because I don't know a doctor who has taken it that seriously.
Yeah. I can't wait to talk to you.
Listen, if we could correct that problem, I would suggest a third of reproductive problems would be over. And my feeling is, before we delve into restorative reproductive medicine, which I believe is a great technology, because it is a technology, we need to get women and men on nourishing traditional diets for at least 3 months and see what their bodies can do on their own. And of course, advise them on sleep, on stress, on exposure to light, et cetera, et cetera. But if we could just correct nutritional deficiencies, shortfalls, insufficiencies, whatever you want to call them, on a population-wide level by recommending a few key foods, we would do so much service in this country to correct this problem. I have been speaking about this for years, and it's fallen on deaf ears at our federal agencies. They've had their own agenda. I'm hoping we have a new agenda with the Trump administration and Bobby at the helm of this amazing organization we have now. But I'm a bit on a soapbox because I actually don't think in many cases it's as complex as we think it is.
Oh, yeah, I agree.
Thank you.
Yeah. That's fantastic. So speaking of the administration, Andrea, consider a hypothetical scenario. Secretary Kennedy comes, he hands you a magic wand, and he says, we want you to fix OBGYN care in the United States. And I, for one, am very excited to hear your thoughts on this. But in particular, you've described how heavy periods and conditions like fibroids are early signs of deeper metabolic issues. So I want you to do 2 things. One, can you explain to us how what's happening in the uterus might actually reflect what's happening in the rest of the body, like the heart or the liver? And as an OBGYN, if you were given this magic wand, what you would want to see for the future of care going forward?
Wow, yes, very excited. So the interesting thing is that the uterus is made of smooth muscle, okay? And smooth muscle is a very pliable cells, these wonderful cells that stretch in order to, basically, carry a baby. But smooth muscles are actually the same muscles that are comprised of our arteries and veins, okay? And so when we look at the histology, the actual cells of uterine fibroids are actually made of the same progenitor myocytes, which is a fancy word for precursor cells of atherosclerotic disease. And we've known this since the 1960s. Okay, now what happened? How is it that all of a sudden the treatment for uterine fibroids became hormonal, medication, and surgery? Well, because it works really good a lot of the time, okay? And I will tell you that I've had many patients come to me who are bleeding with blood transfusions, who have debilitating pain, who don't have normal bowel movements because of the bulk symptoms related to fibroids. And so I think that's how us OBGYNs became a little bit pigeonholed in this treatment pattern, because a lot of the time it works really well, okay? But we've also actually forgotten how we've got there, okay? And so I didn't realize, I knew I was practicing informed consent, but I love this new kind of umbrella of all you gotta do is just tell patients just how they got there, right? And then they get to decide. And so when I teach patients about uterine fibroids and gynecologic health, I talk about lifestyle modifications, I talk about medication, and I talk about surgery. All 3 of those things I can do, okay? And then I just leave it to the patient to decide, okay? And I think that's what really medicine should be about, because unfortunately, there are some fibroids and bleeding issues that no matter how much of a low-carb diet, it's just not going to fix it, okay? Because there's just been so much inflammation that has built up. That's where I can offer other options. And so the fact that we've known that the uterine fibroids and inflammatory tissue related to so many of gynecologic problems are actually inflammatory responses to hyperinsulinemia, to chronic low-grade inflammation, to vitamin A deficiencies. Man, with that piece of knowledge, we have so much in front of us to help treat women. Now, if you were to tell me about the magic bullet and what could I offer, I would put everybody on cod liver oil and a low-carb, high-fat diet, okay?
That's fantastic and ties in very well for my next question for you, Victoria. Outside of these very clear remarks, I think there is maybe an ongoing cultural confusion about the role of carbohydrates. My husband and I just went on a 21-day keto diet with some friends of ours. My husband on day 2 came in the house eating chicken nuggets and said, "This is keto, right?" And I just looked at him with this like disappointed, sinking feeling. So he's struggling. The rest of us are trying here. But there is this question about like, what role do carbohydrates play? I was just listening to a podcast where they said, well, you always want your balanced diet where you have your carbs, your protein, your fat. This is how you do it. So I was wondering within like that sort of like cultural confusion that we have around health, how you, maybe if you could speak to like how you personalize carb intake for women, particularly in light of insulin resistance, and what your food first strategy looks like in the care that you provide.
Sure, yeah. Well, I think overall, carbs are ubiquitous. Carbs are going to be available all the time, everywhere. When it comes to insulin resistance or any, again, even if it's like the beginnings of that, or they're all the way at the other end of the spectrum and they're already type 2 diabetic, right? There's a whole spectrum of things that can be happening. And PCOS is kind of on that spectrum typically. But there's, people they cannot be meeting the clinical level of prediabetes or diabetes, but they still have insulin resistance going on. It's very important for us to know because insulin resistance can be happening for 10 plus years and ever before your numbers get to a point where like, oh, okay, now you're pre-diabetic or whatever. So good to know. When it comes to carbohydrates, we have to understand that like when you are having insulin resistance going on, you are going to be intolerant to carbohydrates to some degree. Your body is responding in that way. So we do need to change or at least strategize what your carb intake is going to look like. Now, on one side of the spectrum, there is going as low as being on a ketogenic diet. That could be, it's quite low carbohydrate. On the other side of the spectrum, though, there could be, a more manageable approach would be, more moderate intake. Now, what is that moderate intake? That there is no consensus on that, and I think that is interesting. And now that can depend on the person, though, too. But there's also a lot of nuance with this conversation. As you mentioned, your husband having the chicken nuggets, like, okay, well, first of all, they're breaded, they're fried. Maybe it's not the best choice anyway, and there are some carbohydrates in there. But even so, even on like a ketogenic diet, I think that whenever something like that goes mainstream, we have to think about the quality of it. How are people actually implementing this? Just because you're keto and there could be benefits with that, the way that someone's implementing that can be vastly different and could actually be in the background creating more issues if they're still not getting nutrients like vitamin A or something like that, right? So we have to think about, yes, carbs need to be strategized as a huge part of the insulin resistance treatment process. We also have to think about there's other things that impact insulin resistance that aren't carbohydrate related though. So the ability for blood or sugar in our blood to get inside our cells, or even insulin to get inside our cells or to be received at the cell. Any hormone needs to be received by our cells. We need nutrients for that to happen too. So, and we need to also not have other barriers to that. Like lots of stress can cause a lot of downstream impacts that can create cellular resistance. Again, I don't want to go too granular, but going back to carbohydrates, we do need to strategize with this. However, my approach, what I typically do with my clients, at the very least, we need to be getting them eating enough protein, healthy fat, and then carbs do need to be managed. But if they are if they are able to switch to at least real whole food carbs most of the time, they're going to have a little bit more flexibility with how much they could potentially have because we're also getting all the fiber and nutrients as part of those carbohydrate foods too. But it does need to be strategized, and I think so often it's either carb or no carb, and that's like all the conversation stops at. And there's so much more beyond that of quality. Also depends on the state of healing too. So if someone is very metabolically dysfunctional, they are going to probably need to manage carbohydrates and strategize them and reduce them a little bit more than someone else further along this journey. Again, metabolic flexibility can actually happen with time, but that's going to require consistency with getting more protein in. So many people are just protein deficient and amino acid deficient. That's a huge thing, right? So they need to be getting enough fiber in their diet too and other nutrients. Over time, as you mentioned, maybe they need to be on a ancestral type of way of eating for several months. That would be something that would create more metabolic flexibility, and they might be able to tolerate more carbs as that process goes on. There's a lot of conversation, especially on social media though, about like specific number of carbohydrates, where I will get doctors who will have a client come to me, they'll refer them and say, their client will say, oh, you're telling me to reduce carbohydrates, but my doctor said you need to be getting at least 200 grams of carbohydrates to support your hormones. Yet they are incredibly insulin resistant. We have to, that person does not necessarily need all these carbs to support their hormones. Some might be supportive for them. It really depends. But I think that there's a lot of cultural conversation or social media conversation happening that's different than what needs to be personalized for that person in their particular health. So I'll leave it at that.
That's fantastic, Victoria. So, Jenny, I have a very specific question for you. One I'm sure you're more than up for the task. So you often use, as you talked about earlier, advanced lab testing and cycle charting in your practice. So and you can take the specific, you can step out a little bit, whatever makes the most sense, but how do you integrate fasting insulin with HOMAIR or OGT insulin curves, and you can explain that to the audience, with real-time cycle data to shape interventions for patients with PCOS or recurrent miscarriage?
Great question. So I really agree with you. When someone comes to me, I don't really care about their diagnosis many times. I'm really looking at what the lab work in front of me and also the person in front of me, right? And their cycle health is their fifth biomarker, really telling us what's going on with their hormones. So the research does show that those with insulin resistance are more likely to have longer or irregular cycles and more anovulatory cycles. So just by looking at someone's cycle chart, if they have delayed ovulation or irregular ovulation or signs of no ovulation, I can right there, really say, there are signs of metabolic dysfunction, and then I can marry that with what I see in the lab work to say, yes, there's metabolic dysfunction going on, and let's go ahead and adjust your diet, accordingly. And one thing I want to branch off, from what you were saying, right now our dietary recommendations for carbohydrate consumption is up to 45 to 65% of our calories should come from carbohydrates. Whereas we're really seeing in the research that we really need to decrease carbs to less than 40% to see improvements in insulin resistance, and therefore we do see in the research when we do that benefits on cycle patterns and improvement in regular ovulation. And so this is so important to me because I have the study here that in women with not PCOS, they did not have PCOS, who used Clomid, which is a very familiar, regularly used first-line fertility drug. Women who had insulin resistance, 20% of women, infertile women, had insulin resistance, and 95% of the anovulatory subjects had insulin resistance. Only 5% of those who were insulin resistant conceived, and none of the women with anovulatory cycles conceived. So I think that in medical practice, most times we just associate PCOS and insulin resistant. And there is this whole group of population of women who are insulin resistant and do not have PCOS, and it absolutely is impacting their infertility. And I always say, if you have insulin resistance, you do not have unexplained infertility. I can explain it to you,
Yes.
right? And so that is, it really needs to be assessed. And then again, it's also not a conversation of you do not need to usually cut carbs. Again, based on the research, upwards, you could have 35 to 40%, I'd go downwards of like 35% of your calories coming from carbs, and that's a decent amount, and very balanced and easy to do if you're using whole food carbohydrates. And in our dietary recommendations as well, right now the recommendation for protein intake is about 10% of our calories coming from protein. And in the research, upwards of 20 to 30% of calories coming from protein, we see improvements in metabolic effects, improvement in cycle patterns. So I think one of the really big changes that we need to make, and what I do when I see this metabolic dysfunction, is change that plate method. So I think in the dietary guidelines, I was reviewing them a lot before this, I think they have the right plate method using that instead of the pyramid. Some people forget that we've actually moved away from the pyramid and we're actually using the plate method now. But I think if we adjust that plate method a little bit more, we'll see a lot bigger improvements in metabolic health and cycle regularity. So yeah, I'll say in my practice, we change the carbohydrate consumption to kind of match where they're at, improve the quality, of course, nutrient-rich diet, eggs for that preformed vitamin A. Maybe some people are getting some crazy. And we put that little secret sauce together and we see some really great improvements.
Emma, may I interrupt? Before you ask me this question, I actually would like to address some of the things that my co-panelists have said. I think they said some great things, but I did want to say, number one, that insulin resistance is definitely a problem, but we can't just address it with diet. It has to be physical activity too.
Yes.
Okay, and that's tough for a lot of people. They've limited time. But once we get their energy levels up with a more fully nourishing diet, we see that type of improvement, and then better sleep will lead to, and it all goes together. But the thing is, when you reduce carbohydrates, and if you do it too much, you can do it a short period of time in women, but you will disrupt their cycles on a keto diet or on a very low carb diet that's not keto. And also, we have to remember that insulin signaling, which is generally promoted mostly by carbohydrates, and of course we want the right kind of carbohydrates, is needed for the conversion of free T4 to free T3, so it's needed for the thyroid. And it's also needed, you may not know this, but it's also needed for the production of glutathione in the body, which is the most important antioxidant that protects the sperm and the eggs. And so I rarely recommend a woman goes, well, almost never on a keto diet, unless they, for some reason, feel short term they want to lose 10 pounds in a couple months. But it can disrupt their hormones, and that can take a while to come back. And the other thing is the high protein diets. It depends on what you mean by high protein. A lot of high protein diets aren't really that high protein if you're talking about percent in calories, because women are already on fairly low calorie diets. But during pregnancy, see, the diets that I recommend usually are something I say, I want this to be fine when you get pregnant. Because I don't know if I make these dietary changes if they're not going to be pregnant next month. I don't want them going to pregnancy on a keto diet. I don't want them to go into pregnancy, with a poor diet in whatever way. But the thing is, anything that I say, I have to assume they could be pregnant. So I'm not telling them to go on a keto diet in most cases unless they're using contraception. Because they'll say, well, I haven't been able to get pregnant. I said, well, that may be changing. So we're going to assume that's going to change, and we're going to put you on a diet and nutritional plan that's going to cover you when you're pregnant. And excessive protein, I usually tell women to shoot for 25 to 30 grams a meal, and I educate them on that. But it's not indicated during pregnancy. In fact, there's enough research on it saying that it is deleterious to go over maybe 100, 120 grams, and I would shoot for 100 generally. We know that the Brewer diet recommends more protein, but it also recommends other things like high calcium foods. So we have to really look at the complete body of literature and the human experience and the human ancestral dietary patterns, and what did they do? We do not want to be reinventing the wheel at this time. And so I'm not disagreeing with what my co-panelists said, but I think there is a trend, more protein the merrier. I don't know that that's true, and let's go lower in carb if we can. That's not a balanced diet. And then the one other thing I'd like to say is regarding the protein, it's really important to get the collagen sources of protein, as well as the animal proteins that we think of the muscle meat. And of course the eggs for vitamin A, and the organ meats, that's a tough sell now. But something like that, or cod liver oil for the preformed vitamin A, because the beta carotene is not going to cut it for a lot of people.
Yeah, that's fantastic. Goes right into my question. So as a bit of a cultural experience, I recently watched the first episode of The Dukes of Hazzard. I don't know if some of you have seen it. It's so politically incorrect. I was like a little horrified watching it. But the reason it applies to this conversation on nutrition is in the first episode, it introduces Boss Hogg, the main money guy in town, whatever his role is. And every morning for breakfast, what does he have? A cup of black coffee and raw liver. It was disgusting. I was just like horrified, and he just sat there and ate it. But it made me think of pregnancy. The best I could stomach was some liver pills during pregnancy to try to up my iron. But what I wanted to throw over to you in relation to that is, can you tell us just a little bit more, like very specifically, like why is vitamin A intake so critical for women, especially in pregnancy? And why have we seen so many women really scared away from vitamin A sources that they need, especially in that crucial time of development?
Wow, you're asking me? Do I have 2 hours? I wrote 2 papers on these topics, one on vitamin A during pregnancy and one on vitamin A for fertility. Both were published in the Wise Tradition Journal of the Weston A. Price. I don't think actually there's a more critical nutrient for reproduction and growth. And if you look at it every step of the way, it's even to the way we regulate our hormones, the way we create progesterone, the way the endometrial lining is formed and ready for the conceptus. But also, which I don't think, this has not been studied, I'd love to see this study, but I believe the fallopian tubes can become closed without vitamin A.
Yeah.
Oh my goodness. I found my soulmate. A doctor who believes in what, because the cells that line the ciliated cells that line the fallopian or oviducts are the same morphology as the cells that line the lung tissue. And we know in lung tissue that those cells become flattened and unable to produce the mucus they need. And that's what's happening in the fallopian tubes, I believe, in a lot of women. And sometimes it can get to the point that it's irreversible because they become so damaged. Those tubes are so small. And then the other thing is, oh gosh, I just lost my train of thought thinking about vitamin A. But what happened, I'll think of it, I'm sure I will, the fallopian tubes. Anyway, the fallopian tubes are so amazing. They are so underrated in the conception process. There's just like, it's like an incredible venue for the sperm and the egg to do their dance. But then the other thing is, and I just lost my train of thought again. I just thinking that dancing. Yeah.
How crucial,
the reason people need more vitamin A is that a third of women, men, of probably more, and I actually happen to be one of them. This is why it's so near and dear to me, because 25 years ago, I learned about the Weston A. Price Foundation diet. And at that time, I didn't know it, but I had vitamin A deficiency. And I looked at it because I thought, oh, soy is a great protein to start using because, I was like, I wasn't a dietitian, I was a nutrition major. I'd graduated, but I never became a dietitian at that time. And I started reading this stuff and I go, how does this make sense? So I experimented with this stuff and you know what happened? My irregular cycles at age 40 went to 28 days, like clockwork. And I had bumps on the back of my arms. I had dry eyes. I couldn't tolerate bright sunlight. All that went away. And I knew that it had to be the vitamin A the more I read about the articles in the Weston A. Price Journal. And I'm like, wow. It took me several years to become a dietitian. I first started working locally in teaching people about these principles, just having a chapter and doing some, anyway, I don't want to monopolize the time, but it was life-changing for me, and it's been life-changing for my patients. And it doesn't cost a lot to do this. And I want to make this accessible to the American public, and I think we can do it. I really do.
Well, you just diagnosed 3 of the 4 symptoms I've been trying to deal with, so we should talk after this panel. After this conversation, one of the things that I would love to do is actually have our panelists put together a few of their resources and maybe even their website or recommended doctors so that you all attending this event have the opportunity to dig further into the literature, but also find a good nutritionist, dietitian, healthcare professional who can really help you dig into, that part of your life and metabolic health. So that's something I'll ask you afterwards. We'll send that in a follow-up email, but I think these conversations are so often best had on that one-on-one basis, really digging into, the nuance of your life, the food you're eating, the lifestyle you're living, the sleep you're getting, and that really is, I think, the epitome of this personalized precision medicine that we are promoting and want to extend to every woman in the United States. So please join me in thanking these panelists for their time with us today.
Okay, we're going to get started. I'm very happy and honored to be able to introduce the panel on root causes and restorative reproductive medicine. We're very lucky to be joined by experts on this panel who will be telling us about their experiences. First, I'd like to introduce Grace Emily Stark. Grace is the editor-in-chief of Natural Womanhood, the online magazine of fertility awareness and women's health, and host of the Natural Woman podcast. Grace is as a trained instructor of the symptothermal method of fertility awareness, a former fertility patient, and a body literacy advocate who wants every woman to understand that her fertility is a feature, not a bug, of who she is. A passionate advocate for education about and access to restorative root cause treatments for reproductive issues. Grace holds a bachelor's degree in healthcare management and policy from Georgetown University and a master's degree in bioethics and health policy from Loyola University in Chicago. Dr. Marguerite Duane is a board-certified family physician, co-founder and executive director of FACTS About Fertility, an organization dedicated to educating medical professionals and students about the science supporting fertility awareness-based methods and restorative reproductive medicine. Dr. Duane serves as an adjunct associate professor at Georgetown and associate professor of restorative reproductive medicine and director of the Center for Fertility Awareness-Based Education and Research at Duquesne University's College of Osteopathic Medicine, and she cares for patients via a direct primary care house calls-based practice, MD for Life. Dr. Patrick Young is a fellowship trained in minimally invasive gynecologic surgery and spent most of his career in academics thus far at Duke University and St. Louis University for 15 years, almost 4,000 cases and multiple landmark publications. He founded the Restore Center for Endometriosis to pay forward what benefited his own wife in relieving debilitating pain and leading to recurring natural fertility. And to enter the conversation among centers of endometriosis as the only center dedicated to treating endometriosis that does not offer to refer to IVF. Dr. Tracy Parnell is a restorative reproductive medicine physician and researcher who serves as Global Director of Communications and Development for the International Institute for Restorative Reproductive Medicine, an organization founded in 2000 to represent RRM medical professionals in the United States and worldwide. She's a managing editor for the Journal of Restorative Reproductive Medicine with a special interest in PCOS and endometriosis, and medical director for the RRM Education Group, which brings leading experts together to train professionals in RRM-focused care. Welcome, and thank you so much.
Thank you.
Grace, I'm going to start with you as a former infertility patient and as someone who's come into exposure to both mainstream and non-mainstream infertility treatments and restorative root cause approaches, noting that the latter prioritizes building healthier habits and hormonal balance. Can you share what your journey taught you about the differences between these approaches, and in particular how restorative treatments focused on long-term health that made you a healthier, happier person?
Yeah, thank you for that question. Can everybody hear me? Okay. Hello? Okay. Now you can, right? Thank you for that question, Deborah. And before I answer it, I just want to say, I know they say never meet your heroes, but there's so many personal heroes of mine in the room today, and what they say is wrong. It's wonderful to meet your heroes and to have them all gathered in one place. So I just want to start by saying that. My story did start with my own infertility journey, and it's really the reason why I do what I do. I have the typical story that so many of us do, where I exercised a lot, lost a lot of weight in college, and lost my cycles. And when they came back, they were never the same. And I got married and was not able to get pregnant right away, despite being 22 years old. I had an idea, fortunately, that there was root cause treatment. I knew enough that I wanted that kind of care, that IVF was not something I would want to pursue. And I'd been fortunate to learn about fertility awareness when I was engaged and had learned to chart my cycles. But it was a year or more of trying to get pregnant and trying to balance my hormones with a restorative reproductive medical professional, and a miscarriage. And the miscarriage is what put me into contact with kind of the conventional infertility treatment side of things, because I didn't miscarry at home. I miscarried while on vacation. And I had an appointment with a doctor who is not my normal doctor, who very quickly, upon learning that I was young, relatively healthy, and had been struggling to get pregnant for a year, almost jumped to offer me IVF. And the interesting part of this is that it was at a military medical hospital, where I was told, you know, they say the military doesn't cover it, but there are ways around it. Would you like to pursue IVF? So this was a doctor who knew nothing about me, about my cycles, about my journey, my struggle to get pregnant, and yet he was ready and willing to offer me IVF almost immediately. And it was such a contrast between the care that I had been receiving with my restorative reproductive trained doctor, just that quick fix, here's what I can do for you, versus the very careful, admittedly slow, but process of getting me healthy, which is what my other doctor was working on. And the next cycle, we changed some things up with the hormonal balancing that we were doing, and I conceived. And that's my 8-year-old today. So, and I've gone on to have 3 healthy pregnancies after that. So I have 4 beautiful, healthy children that I don't know that I would have without the journey that I went on. And it lit a fire in me to give this information to more women so that they knew that they had better options, so that especially when they are offered what seems to be that kind of quick fix solution that can be so enticing when you've been struggling for so long to get pregnant and you have the pain and the trauma of a miscarriage, so that they don't jump for that they hold out, that they know that there's something better. And yeah, that's why I'm here and why I'm doing what I'm doing.
Thank you so much, Grace.
Sure.
Dr. Duane, this is a question for you. You emphasize that restorative reproductive medicine treats the root causes of infertility to restore natural fertility. Can you tell us a little bit more about these approaches and how they address the underlying conditions? What is exactly the mechanism for addressing the underlying conditions, and what makes these methods more effective than some of the traditional, conventional treatments that bypass the root causes? And if you could speak a little bit about root causes.
Yeah. Absolutely, and thank you again, Deborah, for inviting us and bringing us all together today. I do want to just start out a little bit with my own story to medicine. I decided I was going to be a doctor November 2nd, 1979, when at the age of 8, I sat at my mother's feet. She was nearly 40 years old and gave birth to my baby sister at home. So from a very early age, I came to appreciate the power of women and the beauty of natural childbirth. And again, that inspired my call to medicine, and in particular, my call to family medicine. I loved the idea of caring for the whole person. As a couple of people have alluded to today, we can't look at people as individual body parts or widgets. We need to look at them as a whole person in the whole context of their family. And as a family physician in particular, we're very focused on prevention and diagnosis and treatment. And for me personally, I had never learned about fertility awareness-based methods, cycle tracking, any of that when I was a medical student, or when I was a college student, and like most college students, presented to student health with a cycle-related complaint and was offered the birth control pill. Knew none of that other than the pill is the panacea for all that ails women. And if you have irregular cycles, we have a pill for that. And if you have painful periods, we have a pill for that. And even as a college student, I knew that didn't make sense, but I didn't know any better. And it was when I was a resident at Lancaster General Hospital in Lancaster, Pennsylvania, where I live now, I was first exposed and learned about natural or fertility awareness-based methods and restorative reproductive medicine. And like most women and most physicians, when we hear about it, it was this aha moment, right? Initially, I felt that anger, like that shock and that anger. How come I've never learned about this? And as I reflected on my own story, realizing like, oh, there's more to this. And so I just went on a personal journey to learn more and learned about all of the different methods. I started charting for myself. I was single at the time, but realized this was a great tool to understand my own body. I was able to address my own cycle-related issues through charting, lifestyle changes. Yes, using medications. Sometimes medications are necessary, but it was incredibly impactful. But when it comes to infertility in particular, one of the things, I just came from giving a talk on Wednesday, spent all day Wednesday speaking about 50 medical students from all over the country, which is so encouraging to have medical students that are interested in learning this. And at FACS, so that's what we focus on, is on teaching the students and the healthcare professionals that are new to this. But one of the things that I teach is that infertility is not a disease. Infertility is a symptom of other underlying diseases. And as a doctor, it is my duty to diagnose what is that underlying cause of infertility, right? The way our culture conventionally approaches infertility through IVF is it treats infertility as the disease. And as such, with IVF, we create the embryo in the test tube, right, or in the petri dish, and if in fact infertility was the disease, then that should be sufficient. And when we transplant these embryos, transfer these embryos back, we would expect to have a 100% success rate because we've already created the lives. But the reality is with IVF, the success rates are much, much lower, anywhere from 3 to 33%. And honestly, it all depends on who's calculating. Dr. Young and I share a mutual patient who came to me after having gone through IVF. She had had 8 embryos created. She had had 1 transferred, which, thankfully resulted in the birth of her baby boy, but had 2 more transferred that didn't result. And so she was told she had a 33% success rate. But she had had 5 other embryos created that they wouldn't even transfer, and yet they didn't include that in the denominator. When she came to me, she said, I'm either going to see you or I've got an appointment at the end of the month to go through another round of ovarian stimulation and egg retrieval. And what she described to me, before I even saw her for the first time, she reported a classic history of endometriosis, starting at the age of 15, put on birth control for 20 years, had back surgery for back pain that was actually endometriosis related. I gave her Dr. Young's number. I was like, call and get an appointment because you're going to need it, and there's a wait list. And then I saw her, and she had other issues. And this is the thing with infertility. It's oftentimes not one factor. It's often multifactorial. And the other thing I want to really emphasize, especially when it comes to infertility, I know this is a panel and a roundtable on women's health and fertility. Infertility is not a women's health issue. It's a couple issue. 30% of the time, infertility is due to a female factor. 30% of the time, infertility is due to a male factor. 40% of the time, it's both. And in almost every single one of my patients that I care for and treat for infertility, I identify and diagnose multiple underlying causes that contribute to the infertility. And this one patient that Dr. Young and I shared, she also did have insulin resistance. And I was working with her with that, with medication and with lifestyle changes. And then I remember calling Dr. Young because when she was there for my first appointment, she's like, this was in December, she's like, I don't have my first appointment with Dr. Young until March. And I'm like, well, that's way too long because you're 40. And I called him, I texted him like, Patrick, can we get her in sooner? And 15 minutes later, his office staff called her. She's like, it's Dr. Young's office. I'm like, well, answer the phone. And she got in to see him a couple weeks later and actually had her surgery even before her first appointment was originally scheduled. And I'll let Dr. Young tell you the rest of her story. But to your point, with infertility, it's multifactorial. Sometimes it's as simple as thyroid. I mean, Teresa Kenny talked about the woman who presented with thyroid disease that was visible. And this is something, again, I know a lot of women and couples are frustrated, patients are angry that their doctors don't know this, that they didn't offer this. And I encourage women, give your doctors grace. We do not learn about this. Until we started FACS and started teaching an elective through Georgetown University, which is the only elective of its kind, this is not in the standard medical school curriculum. Yet through FACS in the last decade, we have trained over 1,000 medical students, right? When I started this work a decade ago, we were doing a study on a shared decision-making tool. We could only identify 500 clinicians in the United States and Canada that were trained. So we've already doubled that number. And the good news is it's brought the attention to medical schools. And so last year I started a new position at Duquesne University, which is the first medical school in the country that is now integrating fertility awareness education at every level of the medical school curriculum. And we need to do that so that every woman and every man and every young girl and every boy has access to this care, the body literacy, the education, the empowerment.
Yeah. Thank you so much. Thanks for your leadership and bringing this to doctors who so need it, right? And I think that's a really great point. You know, we have to develop capacity as women ourselves. We have to teach our daughters. We have to make sure that we're educating in the proper way. But if there's no receptivity in the medical community, then it doesn't. The conversation stops right there.
Doctors are the ignorance of doctors is the number one rate limiting step to the wider spread adoption of fertility awareness-based methods and restorative reproductive medicine. So this is the key barrier that we need to overcome.
Okay, Dr. Young, since we've heard a little bit about your approach, you've pointed out that many of the patients with endometriosis are misdiagnosed with unexplained infertility, and that ablation, which you're going to have to explain to us what that means, leads to high rates of repeat surgeries. While your approach aims for a single effective surgery, which I think you call one and done, is that how you refer to it? Where does endometriosis originate, I guess is a good question. And I think a lot of people in the room we've talked a little bit about potential root causes for endometriosis rather than it being the root cause itself. So I guess that's the first question. And the second question is a cure possible that could eliminate the need for surgery, or is a restorative surgery currently the most promising solution for long-term wellness and fertility for women suffering with endometriosis? Sorry, that was a bit of a hard ball.
That's a lot there. Well, first off, just to say, I'm so thrilled to be here. Thank you so much to the MAHA Institute and to the Heritage Foundation for inviting me. This is just a great moment in our society to be talking about this, and a recurring theme that kept coming up in the previous sessions and now this session is that women deserve better. Women deserve better. Our medical system somehow at one point went off track, and we need to get back to treating patients. In the world of endometriosis, so quick primer on that. Okay, what is it? It's where the cells which line the uterus and are shed during the period are found outside the uterus in a wrong location. And this condition is associated mainly with pain and infertility. It is very common. So the mantra is often it's 1 in 10, but it's way more common than that. There's a TED Talk called The Most Common Disease You've Never Heard of. I love that title. Everybody knows somebody with endometriosis. It's at least 50% in women with infertility, up to 80% or more in patients who do not feel better when taking hormonal suppression for pain, like birth control pills. And from our database at St. Louis University, it's over 90% in patients with both pain and infertility. So the usual treatments, the status quo, I call it, for what is offered to women for pain, which is Band-Aid therapy, we'll talk about that, or fertility bypass therapy, or even this idea that you're going to have surgery every couple of years for the rest of your life once you start to have surgery for endometriosis, is not satisfactory to most women. You know, to the point about where we're at these days with women's health and infertility, you know, I always say that like mainstream or the usual way that we treat women's health would be so boring, really. You'd be writing birth control pills all day, every day for any condition that comes through the door. For endometriosis, we talked about how it's birth control pills usually, which is really using hormones against the body, not with or for the body. Nowadays, actually, it's worse, or it's more aggressive. It's now medications that induce a state of chemical menopause. Yeah. In fact, I would say chemical castration. Why do I say it like that? For dramatic effect. but really, Lupron is kind of the original, okay? Lupron is used in men with prostate cancer. Lupron is used as a puberty blocker. And now we're giving this medication to young women and saying this is great for your endometriosis-associated pain. But they don't tell you what it's actually doing. The newer medications are basically Lupron in pill form. It's the exact same type of drug, Orilissa, Myfembree. These medications can have very serious side effects, the least of which are menopause symptoms. It can have severe mood changes. So there's a Lupron Victims Awareness Hub website online where 20,000 women talk about their serious side effects with Lupron. I think it's just a matter of time before we see that with these other medications, these oral medications, because it's the same type of drug, like going crazy type of side effects. So it's Band-Aid therapy at best. You might feel better if you can tolerate the side effects, but it does nothing to actually remove the disease or even prevent progression of the disease, which is a common belief that's not proven, that you need to be on long-term suppression until surgery to keep it from growing or after surgery to keep it away. Neither have been proven, and I'll tell you our data. On the fertility side of things, it's bypass therapy. And the way I will tell you a story about that, just to make the point. So an IVF director herself asked me, who is the most important person in the IVF clinic? Okay, you get a second to think about that. Say again? The baby that's being created. That's not the answer given. Okay, first off, it's not the IVF director herself, okay, who got into med school, went through med school, did a residency in OBGYN, did subspecialty training in reproductive endocrinology and infertility, and now owns and directs the IVF center. It's not her. It's not even the patient. She posed the question and then gave the answer. It's the embryologist. It's the person running the lab, because that's where all the action is. This to me was mind-blowing. The patient is not even the one being treated for fertility. And really, if you think about it, she's kind of reduced to just being the one to produce the eggs for the lab. And then the IVF director has really become the one who just transferred the embryo made in the lab back to the woman. But we've lost the patient. 40 years ago, 80% of reproductive endocrinologists and infertility specialists were surgeons. They were still focused on trying to optimize the anatomy and treating patients. Nowadays, in the 20s, it's the exact opposite. 20% are surgeons. We've lost this idea of treating the patient. Anyway, in the world of endometriosis, the usual way to treat this disease is if you see an implant, they try to destroy the implant with energy. It's called ablation. That's the usual way most GYNs treat this disease. The problem with that is if it's widespread surface disease, it's like trying to paint the wall with a pencil tip. If it goes deeper, you're literally charring the tip of the iceberg. You don't get under the roots of the disease to get it out. And people should not be burning near vital structures. So our approach is to cut it out. It's called excision. We cut around it, we cut under it, under the roots down to normal healthy tissue. And we can do that even on our near vital structures. So when they say the rate of repeat surgery after, again, the usual ablation is between 50, 60, 80% in 1 to 2 years, again, expected every couple of years. They're looking back, seeing endometriosis again, saying it's come back, but really they're seeing the same disease from before that was either not treated or partially treated. They're really seeing persistent disease, not true recurrent disease. They're really seeing the same disease over and over again. So we did a study. We tried to get some long-term data, 10-year data, and our rate of repeat surgery was under 5% in 10 years. Because we're actually removing the disease and preventing adhesions, which is where things can stick after surgery. which is also very important. So this is where the idea of one and done surgery arises, which no one thinks is possible. And it's true, you know, there's no cure per se, but I think this data shows some very important things. Number one, that one and done surgery is possible for many women, if not most women, if you actually treat the disease well, optimize the anatomy, even without the need for long-term suppression. Most of the patients in the study did not take any long-term suppression post-op. They were either trying to get pregnant or didn't like the side effects. Number two, that one and done surgery should at least be the goal of what centers of endometriosis are trying to offer patients. I feel like surgeons have given up in a way. You know, they might biopsy one piece to get a tissue diagnosis. They're going to burn what is easy, but then whatever they can't get or is too difficult to get, they're going to put them on long-term suppression, which is what everybody does to try to suppress what they can't get. Or for fertility, they're going to bypass the pelvis and just offer IVF. Or just come back and do it again in 2 years. That's a very different surgical mindset versus, I'm going to try to remove it all at this surgery to avoid the need for long-term suppression because it's gone basically, to optimize the anatomy to lead to natural fertility and hopefully recurring natural fertility, and for the hope of one and done surgery. That's a very different surgical mindset, I would say, on behalf of the surgeon. And I think we've shown a very different surgical result for the patient.
Thank you so much. Thank you. Thank you so much.
We need to train more surgeons.
Thank you, Dr. Young. Earlier on, I think Katie Vidmar, it was you brought up Wendell Berry and the sort of the analogy about the health of the soil. And often when I think about treatments that do not look at the whole patient and do not look at, you know, restoring holistic, wholesome, you know, health to the woman, that what we get is the same thing we get when we try to force unhealthy soil to produce good fruit and nourishing foods, right? It's problematic, and I think we can all kind of understand that in a very fundamental way. So, Dr. Parnell, my question for you is, you've highlighted the various restorative reproductive medicines, use of a patient-centric approach, where patients actively participating in the charting of their biomarkers to identify the underlying abnormalities that contribute to infertility. Can you talk to us a little bit more in depth about your understanding of root causes and some of these patient-centered approaches and how that actually works?
Right. Well, firstly, again, I want to thank for the invitation. I was there in 2000 when we first presented the concept of restorative reproductive medicine and when the International Institute for RRM was formed. And our goal at that time was to unite doctors, researchers, nutritionists, allied health professionals, fertility awareness instructors under a banner that would be focused on the patient so that we could cooperate and collaborate to be able to get to some of these really important questions and get answers to them. I do want to define sort of a little bit root cause because I think we all use it a little bit differently. I know when I'm explaining to patients, you know, the root cause, I'm really talking about basic medicine. And I have to agree with so many of the panelists, our system is broken. In reproductive health, we have gone so far away from the classic medical model with difficulties that may be with that, but we don't even diagnose and treat. And so when we, in restorative reproductive medicine, sort of use the concept root cause, we're really focusing on how we're explaining to patients what's wrong and how to fix it. I do want to acknowledge, though, that root causes has a different layer as well, and I think they're actually quite linked. If you cannot explain or understand or find what's wrong for a patient, how on earth can we do research that allows us to be able to identify larger, bigger issues? I mean, epigenetics are substantial things. The environment, you know, turns on and off switches in our bodies, and we know that our environment is so toxic in so many ways. That soil analogy, Deborah, if we have unhealthy soil, if we have an unhealthy body, all the other things are not going to fall into place. So restorative reproductive medicine really tries not only to unify all of us together to work to address these issues, but has a staged approach, which you kind of see across our panel as well. And we have activity, lifestyle, sleep, nutrition as sort of a baseline that we address and discuss with the patients, because it doesn't matter if you're going to focus way high up here and the patient is still eating tons of processed food that's really working against what you're trying to do. And then, of course, we have supplements and nutritional supplements and stuff that can help. And then there's the medical approach. We want to take advantage of the science that's available to us to be able to make sure the patient has optimal health and optimal outcomes for what's important to them. And then, of course, the surgical aspect. So it's a wonderful tiered approach that involves an entire team. And the focus of that team is around the patient. And Patrick, I just found it so telling that the embryologist is the main focus. And that's where our system, like I said, is broken. And that's where restorative reproductive medicine, our goal 25 years ago was uniting with the goal to come up and actually become recognized as a new medical profession that focuses exclusively on finding, restoring, and optimizing reproductive health, and which avoids, and this is a bit of an interesting issue right now with the increased interest in restorative reproductive medicine, we are finding people coming out of the woodwork saying, well, we do that. The caveat for being a member and being part of the RRM community is that we avoid methods that suppress, destroy, and circumvent the problem. And so by doing that, all of our efforts are exclusively focused on what is wrong, finding it, and fixing it based on the patient. And then, of course, the outcomes, as Marguerite said, our outcomes for infertility, well, if you have a healthy body, it's pretty easy to conceive and to have healthy single babies that are born at term. And the premature birth rate in the United States and in other countries is far higher than it needs to be. And so much of that could be addressed by this collaborative effort under the RRM banner. People say, it was 25 years, why haven't we heard of you? Well, you may not be surprised to know that Big Pharma does not entirely embrace us. And that means that much of the research that all of us are doing is paid by our members, is donated, and that does limit the impact that we can do and the changes that we can make. And then the awareness for the patients, of course, if you don't know about something, you can't choose it. And so when we're talking about informed consent, if you don't know and no one's telling you, it's off the table. So I have to keep pinching myself because 25 years ago when we had this discussion and a group of us internationally were all excited about this concept of restorative reproductive medicine. And an interesting tidbit, we were actually in London, UK at the Victory Service Club. And looking back in sort of hindsight, that the victory, I think, is coming now. Boy, there's been 25 years of hard service. But hopefully the victory is coming with all of this movement. And, everybody keeps going an aha moment. And I'm going, well, is that a MAHA moment? And so just really grateful. And hopefully more collaboration is going to do that. And just an interesting point. I liked how you mentioned Lupron as chemical castration. As a tidbit, if you look up Lupron in Wikipedia, not the greatest source for medical information, but you will find it actually is the drug of choice for chemical castration of male pedophiles. It is. So interesting to know how we use it in women.
Wow. I love how you say collaboration is key, and it absolutely is. I mean, I practice in Washington, D.C., but refer many patients to Dr. Young or to Dr. Whitaker, and I think, Patrick, we are like 100%. Every infertility patient I've referred to him for surgery has since gotten pregnant, even couples that have been struggling for years. But funding is critical. To your point, the funding to do the research, like the STORM study, the surveillance treatment outcomes for restorative reproductive medicine, there's so much pushback on those of us doing restorative reproductive medicine. It's not evidence-based. Dr. Phil Boyle, who developed the near fertility method, he says something I love. He's like, just because it's not published doesn't mean it doesn't exist, but we definitely need to do more research and get more publications, but part of that is the funding that's so critical. And IIRRM has been such an incredible leader in that, and we're so grateful for that.
Can I add
something? Yeah, sure.
Yeah, I think it's really important to point out that no one is ever healthier for undergoing IVF.
No.
Right. If anything, your health is destroyed when you undergo IVF. When you treat the root cause of infertility, when you understand, like Dr. Duane pointed out, that it's not a disease in itself, but a symptom of an underlying disease, then you're actually treating women, you're getting them healthier. It was what I experienced as I was undergoing the infertility workup that I had. I was eating better. I was working on better habits. I was exercising appropriately for my female body. I was getting better sleep. Because I was told to pay attention to those things, that those things would have a positive effect on my fertility. I felt myself getting healthier through the lifestyle changes. And then the hormone balancing, the proper hormone supplementation that I was receiving as well. I can absolutely say that my experience of infertility treatment left me healthier. I don't know that I could find a single woman who would say that about undergoing IVF.
The patient that I referred, you wanted to speak to?
Well, if I could just add to that to say, there was a thread on a group for endometriosis where women talked about how they had known or suspected endometriosis, got pregnant through IVF, but then as soon as they delivered the baby or stopped breastfeeding, the pain came right back to the point that it really affected their ability to care for the child and even bond with the child. And we were like, why didn't, we thought maybe they should have treated the actual underlying disease first. But also, yes, there's an absolute link between wellness and fertility. The better a woman feels, I strongly believe, the better her chances for fertility.
Right.
And what we're talking about here is not just philosophical. It's actually very effective. So when you optimize the anatomy, the hormones, and the functioning physiology, success rates for pregnancy are up to 70% in 1 to 2 years. That's really, and you're feeling better, and it can lead to recurring fertility. When compared to the success rate for IVF, which is 32%, I mean, that's really good. So this works and works well.
So I guess just a final question in the interest of time. I know that each of you is very passionate about this, and I appreciate all of the perspectives about this, treating the whole person, really reclaiming kind of women's health in a way that doesn't just, put a Band-Aid on something, but restores her vitality and allows the family to thrive and allows her to have children. And obviously this has long-term implications for her health and the health of her child. If there's anything from the other panels, I was just thinking so many of the other panels who talk about nutrition, metabolic health, informed consent, body literacy, they all seem to weave in quite beautifully with this approach. In fact, I feel like each of the prior panels are a part of this approach as well. They're integrated into this approach, which is kind of a nice segue to saying, what ways do you feel in your practices could we make this more accessible to more women who want to choose this option? Do you have any final thoughts on that?
I mean, personally, in my practice, I do a direct primary care practice because with this, it's a time-consuming endeavor, right? Like with women learning to chart, addressing the underlying nutrition, it takes time, and the current medical system does not allow for doctors to have the time to treat this. And it's so important that we collaborate. Like I worked with nutritionists and physical therapists to address it. And through facts, like 3 of the panels today are going to be speaking at our fall virtual conference on lifestyle and its effect on the healthy cycle, because sleep, nutrition, exercise, stress, all of those are so critical. So I think, a direct primary care approach can open up access, but we have to train more doctors to be able to do this. I have had patients drive 6 hours to see me. I have had patients fly from halfway across the country to come see me. We need to be able to train doctors so that people can access this in their own country. The fact that for the longest time I was the only physician in our nation's capital licensed to practice restorative reproductive medicine, that's saying something at how just not ineffective, but just how limited our healthcare system is when it comes to providing this care.
And more women need to know about it too.
That's so key. The power is in the hands of the women and the hands of the people here. You're the advocates. You're going to demand and require change because women are tired, and men, there's restorative andrology, it's under the same umbrella, are tired of being gaslit, ghosted, their symptoms downplayed. And the change, I truly believe, starts with this group and the advocating. And we all work together pretty well. I mean, we're not a huge group, but I send patients to Patrick from Western Canada. There's enough of us that we actually work collaboratively, far better than I think our ART colleagues do because they're in competition. We're collaborative. And we have to do that for multi-center prospective trials to actually be able to have enough evidence to actually shut down any discussion in the future that this is not a valid option, because it certainly is. And having that research from all of us in different states, different places across the globe will be definitive in changing reproductive health forever.
But I think it's really important to add that, and I'm borrowing from Katie with this, is that women cannot advocate for, protect, and understand what they haven't been taught to know. And so women need to know that they want this care, and they can't know that they want this care or that this care exists if we take every single 12-year-old that presents at her pediatrician with a painful, irregular period and immediately put her on birth control. Women need to understand that their cycles affect more than just the regularity of their monthly bleeding, that young women on birth control are not laying down proper bone density, their cardiac tissue is not developing properly, their cervical tissue, their breast tissue is not developing properly. And women, girls and their mothers have no idea. And they get put on birth control and they have no idea that there are root cause treatments. And then they see you when they're in their 30s and they're desperate to get pregnant. And they feel betrayed when they find out that this is something that could have been dealt with in their teens. And they could have been able to get pregnant very easily when the time was right for them. And so we have to educate women. That's a big part of what we do at Natural Womanhood, is educating the patient so that they're primed to know and want the services that these wonderful clinicians next to me offer to women. So it's a twofold piece.
Do I have time to add one quick thing? Yeah. So yes, awareness, collaboration. I really try to stay in my lane to do surgery, and I'm taking notes from everybody else to collaborate for the other stuff, for the hormones and the functional medicine and all that. But maybe an idea of developing some kind of network of centers of excellence or something like that. I've said for a long time, or had the idea that research and training for endo is like 30 years behind cancer. So endometriosis is not cancer, but in the cancer world, they talk about personalized care, individualized care, and they have these networks of centers to do research, collaborative research, and training. And I think at least endometriosis or restorative reproductive medicine more generally might take a note from that or something.
Absolutely. Thank you all so much. Thank you.
Thank you so much.
I just actually had a question. How many people in the room have already given birth before? Okay. How many want to give birth one day? Awesome. I'm so glad you're here. This is great. And how many people have attended a birth or been a care advocate for someone? Okay, so most people in this room pretty much understand, what we're trying to get at here, right? That's why you're here, which is awesome. But I wanted to talk a little bit about the power of informed consent and having a care advocate. So when it comes to birth, a lot of women basically just depend on their gynecologist, and this is what we've been talking about all day, right? So I'm not gonna, keep on harping on that, but I did want to talk a little bit about the importance of a birth plan and a care advocate. So I want to talk a little bit about my story. I had a doula, and we created a birth plan, and I was supposed to give birth at a birth center, right? So one of the things that we need to be asking ourselves is, what questions should we be asking when it comes to giving birth? Not, giving just the answers to these questions. So at Mothers to Be, we have a birth plan on our website that you can find, you can download, you can customize it. And one of the big things that we really want to focus on is if you want to have a birth in a hospital setting, if you want to give birth at a birth center, if you want to give birth at your home, having a care advocate who knows your plan is the most important thing you can do to set yourself up for success. So whenever you're moving forward, I'm sure if you're a birth provider, you know this, someone who has a doula, or is it your partner, is that your husband, whoever it is that is with you, needs to know the plan. And so that's why I'm not going to get into all the nitty-gritty details, but if you want to find a birth plan, we have one on our website, and that can actually start with what questions should we be asking whenever we're giving birth, because the sovereignty of the mother is something that I think is left out a lot in our care. The mother should be making decisions in an informed manner, and that is not happening, especially in emergency situations. So at Mothers to Be, we take the stance that even in emergencies, it could be really great and should be the standard of care that we should still give 10 seconds, right? Hey, this is what we might do. Do you want to do this or not, right? Instead of just treating the mother as a patient and letting things happen to her, we want to have her active in the decision-making process, even through labor. And that's why it's important that the mother and the father, or the care advocate, be that a doula, is on the same page about what she wants. And really kind of going through these scenarios, right? Like, one of the things that I had no idea about whenever I gave birth was, I didn't have it on my birth plan either, was placenta delivery, right? So I didn't make a specific note, hey, I want to birth my placenta naturally. And I will spare you the details, but that did not end up very enjoyable for me in those moments. And I think that's where we really have to start, helping mothers finding out what questions we should be asking, right? How should you birth your placenta? Do you want Pitocin? Do you know the side effects of Pitocin? Explaining the cascades of interventions. And I personally take the stance that if you want to do these different interventions, that's your decision as a mother. And as long as the mother's sovereignty is respected, I think that can keep us moving forward in the right direction.
Wow, okay. So let's talk about doulas first. Many hospitals are starting to have doula programs, and some people are applauding that, but I would tell you that that's a problem, because doulas who work for a hospital have a conflicted fiduciary duty. Right? The hospital is going to tell them that they, you can't tell them things that are really their right to know, because the hospital policy doesn't let them. So if you're going to look for a traditional advocate, which I truly believe that we need, you need to have something that's independent.
Mm-hmm.
You also need to have someone that knows your plan really well, because women are mammals, and they labor best when they're undisturbed. And they don't need to be trying to be coerced or bullied or something. That should all be done ahead of time. And that's a problem, because a lot of times when you come into a hospital setting these days, you have no idea who's going to be taking care of you. You may have a physician that you've been seeing the entire pregnancy, but he's in a group of 7 doctors, and they got 1 in 7 chance of that person not being on call. So you need to, when you're checking out an OB, I always tell women nowadays, I'm not practicing anymore, but I tell women nowadays, when you go to your first OB visit, remember, you're the boss. You're going there to interview them. Don't let them take your blood pressure. Don't let them draw blood. Don't sign any forms. You're going there as an interview, and you're going to ask them, what happens if I go past 41 weeks? Can my doula and husband be in the room at the same time? Can I leave the delayed cord clamping for more than 60 seconds? You ask these questions ahead of time and see how they look at you. Do they give you the time of day? Are they rolling their eyes? Are they have one foot in the door to get out the door? Because the medicalized birth model, unfortunately, works on volume. And doctors need to see a lot of people, because, and I'm going to get off topic by talking about reimbursement, so I won't go there. But they have to do volume, whereas the midwifery model isn't about making money. Most midwives know that. They're not going to make much money. But their prenatal visits are an hour long. And so there's a real difference in the model of care. And when you move into a new community, just like you check out where's the Costco, where's the schools, what kind of facilities do they have, check out your hospitals. Before you move into a community or when you get to a community, check them out. Understand that if you want to be informed, you want to know what's going on in your community. And when you have, by the way, to get informed consent, or to give informed consent, you have to be informed. Mm-hmm. And today, the problem is that the medical model is based in fear. And so the information, because ACOG itself says pregnancy itself is a high-risk condition. And if this is the prism by which obstetricians are trained, and the companies they work for manage them, then this is how they're going to see everything, and they're going to skew their consent to funnel you down the path they want you to take. So informed consent is a lovely statement, but it doesn't matter if the information you're getting is skewed. So you really have to know that. And doctors also don't understand what high risk really means, because the medical model of care looks at pregnancy as a high-risk condition, and it looks at that doctors hate chaos, and they want to manage it. And so they look at all pregnancies as something to be managed. Whereas the midwifery model, as I learned over the years of working with midwives, is that they trust that birth is a normal function of a woman's body, that it's designed to do this, and occasionally it will go wrong, but midwives are willing to accept uncertainty. Doctors tend to not accept uncertainty. And what do I mean by high risk not really being a number? Well, it isn't, because some of the things they'll tell you are high risk are less risky than the things they want to do to intervene upon the thing that's high risk. For instance, you talked about raw milk. Yeah. They'll tell you not to drink raw milk, but ACOG recommends 4 vaccines while you're pregnant. All right? Raw milk is high risk. 4 vaccines, never been tested for safety in a randomized placebo-controlled trial in anyone, let alone pregnant women and fetuses, is okay. Or you're over 35. That labels you as high risk. So what do they want to do when you're over 35? They want to induce you. So which carries more risk, being over 35 or having a labor induction? Everybody? Labor induction. But which one's labeled high risk? Being over 35. So, right. So it's about fear, and they're permeated with fear, and that's where we have to change the system. We'll probably get to that in a later question. But advocacy is really important, informed consent. You have the right to information on everything. No one's allowed to touch your body without your permission. And if they use coercion, by the way, that same organization, ACOG, who they follow, like a puppy dog, following its mother, doctors follow that, have guidelines about ethics that say that use of coercion, including the risk of the use of calling child protective services, is never acceptable. And yet people are threatened with that all the time.
So this actually segues nicely. I'd like to ask Sally a question, because Sally talks about diet dictocrats, and there's a fear-mongering and fear basis that prevents a lot of women from actually nourishing themselves the way they need to be nourished to have an optimal pregnancy. So Sally, your work obviously at the Weston Price Foundation emphasizes the critical role of nutrient-dense diets, rich in fat-soluble vitamins for both parents before conception and through pregnancy and childhood. Can you explain a little bit why this traditional dietary approach is so vital for optimizing maternal and child health outcomes, and how it empowers women to make informed choices for their families' well-being during the perinatal period and beyond? And if you want to say a little bit about what you may think is preventing more women from doing this in the work of the Weston Price Foundation and actually facilitating better connections.
Thank you very much, and thank you for having me. So just a little bit of explanation. Dr. Weston Price was actually a dentist, and during the 1930s, he traveled throughout the globe to study healthy, what he called primitive people. And by healthy, he meant they had naturally straight teeth, broad faces, ease of reproduction. When you have the broad face, you have the round pelvic opening, so childbirth is much easier. And they were just healthy in every way. And he wanted to know what kind of diet supported this good health. And he had a laboratory, tested all these foods, and basically the answer comes down to nutrient density. these diets were very high in minerals and extremely high in what we call the fat-soluble activators, or the fat-soluble vitamins, 10 times greater in the traditional diet than in the modern diet of this day. And these vitamins are vitamins A, D, and K2. So where did they get these vitamins? They got them from animal fats. They got them from organ meats. They got them from fresh and fermented raw milk. They got them from seafood. Fish eggs were highly prized for fertility. A very important fertility food was liver, which we have a hard time eating these days. Anyway, all of these foods, butter from grass-fed cows was another fertility food. And all of these foods are demonized, right? High cholesterol, high fat, don't eat vitamin A, it's going to be bad for you. So what modern medicine, modern thinking has done is demonize the very foods that traditional people valued and revered for good health and especially for fertility. So we advocate a nutrient-dense diet at least 6 months before conception, and a lot of these problems that we're hearing about just clear up with this diet, including things like endometriosis and infertility. Our diet includes a quart of whole milk from grass-fed cows per day, 4 tablespoons of grass-fed butter, 2 to 3 eggs, liver a couple times a week, especially poultry liver, fish eggs if you can get them, and no processed foods. And we have had, I would say, thousands of babies born to this diet. Not only does it make for ease of conception and pregnancy, but these babies are absolutely beautiful. I want to say a couple of things about vitamin A, and then I'll stop, okay? So vitamin A has been demonized by one really bad dietary recall study that's contradicted by all the other studies on vitamin A. You cannot make sex hormones or thyroid hormones without vitamin A. And we're talking about true vitamin A now, we're not talking about carotenes. So that's number one reason why it's so essential for reproduction. Number 2, when reproduction occurs, the first thing that happens is an embryo forms. And the cells in the embryo are stem cells. They're undifferentiated cells. And they start to get signals. This signal says you're going to be a heart cell. The heart is the first organ to form. You're going to be a brain cell. You're going to be bone cell, and so forth. What gives the signal? It's vitamin A. Vitamin A is the concert master of fetal development. So even if you can get pregnant on what you're eating now, if you haven't built up your vitamin A stores like the traditional people did for 6 months, you're not going to be able to hold that pregnancy. So I can't stress enough, you just cannot build a baby without vitamin A. And finally, the last thing I want to say is something we're very concerned about is people taking a lot of vitamin D. Because vitamin A and vitamin D and vitamin K, they all work together. Sometimes people take vitamin D and vitamin K together. This is the fastest way I know of to deplete your vitamin A stores. And it can definitely lead to infertility. You want to get your vitamin A and vitamin D and vitamin K in foods. They're usually in the same foods. We recommend cod liver oil for, so you get the A and D together. And you don't need that much vitamin D. You don't need 10,000 units of vitamin D. It's just a way overload. And then you get your vitamin K. The best sources are poultry liver and butter fat. So that's our prescription. Thank you.
Thank you so much, Sally. Kelly, I'm going to move on. I think that we've spent a lot of time today talking about kind of restoring fertility and that being a sort of an optimal approach to becoming pregnant and sustaining a healthy pregnancy and having a beautiful birth. So Kelly, I kind of want to just turn a little bit to some sort of more ethical questions that come up. The Center for Bioethics and Culture, where you're the executive director, highlights the lack of longitudinal research on surrogate mothers and children born through assisted reproductive technologies. Could you share with us a little bit more about the existing research or personal stories that reveal about the experiences of women and why you believe there's such a significant gap in comprehensive data on these practices to date.
For sure, and I really appreciate being a voice here and kind of a little bit different side of things, because I think here we're focused on restoring fertility for women or couples, but I'm here kind of as a voice to women and children in the sphere of technology, reproductive technology specifically. And this is a space, I believe, where the health and well-being of women who freeze their eggs, women who sell their eggs or donate their eggs, surrogate mothers, and the children born of these technologies are being systematically overlooked in current policy frameworks and in our healthcare. So I really appreciate being able to speak on their behalf and share some of the stories. The little studies that we do have, independent research that we do have, and the countless personal stories that we hear in the work of the Center for Bioethics and Culture paint a really dismal or concerning picture of the long-term impacts of assisted reproductive technology, particularly for egg donors, and I use that in quotes because these women do sell their eggs, they don't donate them, surrogate mothers, and the children, again, who are born from these technologies. We know, and we've heard today, that there is a vital connection between a child and his or her biological parents, but there is also an integral and an indispensable connection between a child and the mother that carries him or her. So first, I'd like to talk about surrogate mothers and what we know there. A study most recently in 2024 showed a higher risk for severe maternal morbidity in surrogate pregnancies and adverse pregnancy outcomes for surrogate mothers. Studies have shown collectively that surrogate pregnancies are at higher risk for preeclampsia, gestational diabetes, postpartum hemorrhage or hemorrhage during delivery, and placental abnormalities. I did my own research into this where I interviewed over 96 women in the United States who are surrogate mothers as well. And our studies also kind of confirm this high-risk nature of surrogate pregnancies after a very emotional and physically taxing process of hormones, hormone therapy, and multiple embryo transfers often. These women are much more likely then to deliver via C-section, sometimes 3 or 4 times more likely to deliver preterm, and are more likely to go home with postpartum depression. After delivery, some of the women that I personally spoke to, and I'm thinking of a woman, and I'll share her story in a moment, but they talk about the emotional trauma, particularly when they bond with the child that they're carrying, and they weren't prepared for that because the language of the fertility industry is very manipulative in that way. I recently interviewed Erica, and her interview can be found on YouTube, as most of my interviews with surrogate mothers. And in her contract, she was to have a little bit of contact with the baby right after birth before the intended parents were to take that baby away. But as the baby was being delivered, they grabbed the baby, and medical professionals started yelling, "No contact, no contact, no photos." She was denied time with that child, and more importantly, that child was ripped away from the only home that child's ever known. And so we're talking about the influence of this connection, this in utero connection and pre-pregnancy. I'm getting beside myself because I want to talk about that in a second. But if this surrogate mother does develop any complications during her pregnancy, let's say preeclampsia, which Erica in this story did also develop preeclampsia, those long-term effects don't end when the baby is born. They will follow her for the rest of her life, probably causing chronic health complications later. And to kind of tie that in a bow, preeclampsia, which is a common complication of assisted reproductive technologies, is on the rise in the United States. And if you have preeclampsia in pregnancy or childbirth, you have a future risk factor for kidney disease, stroke, and cardiovascular disease later in life. We know in the United States that cardiovascular disease, which includes heart disease, is the #1 killer of women. So if we put all of this together and go full circle, we can see that there's a dangerously unhealthy cycle for women who are utilizing assisted reproductive technologies or who are being used by these technologies in the case of surrogate mothers. So I'd like to focus just for a second then on that child. This child is created in a lab and it undergoes the stresses of pipetting and other environmental stresses. She or he is carried by one woman and then handed over to another family. And like I said, we know that maternal bonding begins in utero, that a mother's voice, her heartbeat, her emotions, her nutrition, all have a huge impact on fetal development from the very beginning. This child knows that surrogate mother on a primal level, and to dismiss this connection is to dismiss basic biology and human experience. There's a big emotional toll on donor-conceived individuals. I've talked to many of them who talk about the loss of identity, the loss of medical records, and just the emotional part of it. But there's also, we're starting to see now, thankfully, some research in this space that there are health concerns for babies who are born through assisted reproductive technologies. And I'd like to name just a few, but premature birth, low birth weight, developmental or medical concerns like ADHD, cerebral palsy, imprinting disorder, heart defects, high blood pressure, insulin resistance, we talked about congenital malformations, and that's just to name a few. I could go on there. And for the sake of time, I won't include egg donors in this conversation, although I'd like to, because they are such an important part of this conversation, because they are completely lost in medical history. We have no long-term data for these women who might go on to develop hormonal imbalances, a loss of their own fertility, and even cancer later in life. They are completely lost in medical history, and they deserve, again, truly informed consent, which they can't, they're told there are no known long-term risks, and they take that to mean that there are no long-term risks at all, and that's just not accurate. And then I'll answer your question, why is there a gap in this coverage? And the answer is really simple, and it's really uncomfortable, that we have allowed commercial interest to override ethical responsibility. I think if the fertility industry did the research, they'd see the harm and then they'd have to stop profiting.
Thank you so much. It's such difficult stories to tell, but thank you so much for doing so. I don't think most people are aware of just how painful that experience is. And it's so, I feel really humbled by everyone's contributions to presenting today really beautiful, strong options for returning to people what they rightly should have, which is really good health and fertility and life force and creative capacities. And so thank you so much for sharing that. I'm going to move in, just because it's a really nice kind of segue from here, to Stu, just to talk, if you want a little bit, to talk about this, I think what you've talked about a lot, treating birth as a medical emergency. And you argue that the profit-driven, intervention-heavy obstetric model undermines natural birth. What thoughts do you have for addressing the systemic coercion and financial incentives in maternity care to ensure that informed consent is honored, and to prioritize these non-interventionist approaches, especially when complications arise?
There's a lot of forces involved, obviously, and you just mentioned one of them is the financial force. The system is set up to feed a lot of different animals. And, the hospital, the insurance companies, the specialists, everybody's making money and the outcomes are not getting better. Mm-hmm. And hospitals, the people, I don't know if it's the PR departments that are just wacko or what, but recently they had a thing where everybody was trying to be mother-baby friendly. You've heard the term mother-baby friendly. It's like the Good Housekeeping seal of approval. And hospitals tried to get this mother-baby friendly thing, and then COVID came along and they threw it immediately out the window. So mother-baby friendly meant that that people could come and babies would, so it was thrown out the window. So it was really all virtue signaling. But before that, there was another slogan about 10, 15 years ago that said, let's make hospitals more home-like, because they wanted to compete with home birth, which is on the rise, by the way, went up about 30 or 40% over the last couple of years, which isn't a lot when it goes from 1% to 1.4%, but it's still 40%. So That's math. But making hospitals more home-like. So what does that mean to people that work in the hospital? Well, let's put hardwood floors and curtains in there. That's what they did. But they didn't change any of the policies. The women still had to be on their back. They still had to be monitored. They still could only have a popsicle if they were lucky. And all the things that hospitals do that are sort of wrong, just plain wrong. But they're financially motivated. Because you know what? There's no RVS code to bill for not starting an IV. There's no RVS code to bill for not drawing blood on admission. Why does a woman need blood on admission? When we go to the home birth, we don't draw blood on admission. And by the way, when you go to the hospital that they're trying to make more home-like, what's the center of every labor room? The bed. If you ever been to a home birth, how many of you been to a home birth? I like that idea, Claire. It's great to ask. Right. If you walk into a home birth quietly when a woman is in active labor, how often is she in her bed? Never. Okay? So this is how they think. So we have to change that, and the way to change that is to bring back midwifery, not the medicalized midwifery that's happening now with NARM and NMI. They're getting medicalized. They're not using the word woman anymore. These crazy things that are happening in our academia. But to bring in traditional midwives and help them teach. And ultimately, I think to solve the problem, we need to do it, as a lot of you talked about earlier today, we need to get to our teens. We need to get in middle school and high school, not only to talk about your bodies, but also to talk about pregnancy, to teach the boys and the girls about that birth is normal. To teach them that this is a normal process of the body, that when left to the primitive brain and get the cognitive brain out of the room, it usually goes smoothly most of the time. And then for those rare cases where we need something, we have the specialists in the hospitals. The problem is the way the system is set up is that if the hospitals don't take all the normal pregnant women and medicalize them, they can't afford to stay open. They can't afford to just stay open. So their hospitals, like a lot of hospitals now are closing in rural areas simply because they can't meet the guidelines that are being put out. So what does that do? A woman now has to drive 100 miles. How is that safer? So safety is not one definition. If I asked everyone in this room what the definition of safety, I would get 100 different answers. Because some people feel safer in the hospital. But that's maybe because they've been sort of brainwashed to believe that the hospital has their best interest at heart. But it doesn't always have their best interest at heart. As a matter of fact, with the shift mentality, you may get to like the nurse that's taking care of you, and suddenly there's a change of shift. And when you have safety in the hospital, they think, well, I've got an operating room down the hall. Well, let me ask about that. Do you think that if there's suddenly a disaster, like a placental abruption that occurs, first of all, there's probably nobody in the room with you when it happens. You're on a monitor that maybe somebody's watching from the desk or maybe they're not. And somebody comes in and they say, oh, we need to do a crash C-section. How long is it going to take, even in a hospital? You've got to have an OR crew available, you have to have an anesthesiologist available, you have to have a surgeon available. The OB's probably at home, or there's maybe a hospitalist now and he's there, but you have to have an assistant available. To get all that done, maybe you could do it in 10, 15, 20 minutes. If a baby is really in that much trouble, you don't have that much time. So you're not saving anything, but you're changing the way birth is supposed to be managed, which is to be safe, quiet, and unobserved. And the home setting is a much better place. So we need to get to our teens, and one other thing we need to do, besides getting people out of the hospital, as Marston Wagner says in Business of Being Born, is if you want a safe birth, get the hell out of the hospital, is change the way we reimburse. And this is a big issue, and I don't have any control over that. Yeah. But it takes more skill to be to do a vaginal delivery, more time, and yet it gets paid less. The hospital makes more money, probably 2 to 2.5 times as much money by a cesarean section. So what is the incentive of the chief financial officer of the hospital to lower the cesarean section rate of their hospital? Their fiduciary duty isn't to the woman, it's to the hospital and to the board of directors and to the stockholders. It's a complete corrupt mess.
I just wanted to jump in there real quick too about birth centers and midwives, right? So all midwives are not going to, one midwife to another midwife is not going to be the same, right?
That's
So
right.
when you're shopping for a midwife, if you're thinking, okay, I don't want to give birth in a hospital, don't assume just because she's a midwife, she's on the same page as you.
Can I speak to this?
Yes. Adelaide, we have a non-traditional,
You take us home, Adelaide.
non-medical
Take it
midwife
home.
in the room. Adelaide Meadow, can you tell us all about your experience as a midwife and talk a little bit about the distinction?
So first of all, I love that this conversation is even happening, right? I'm here as a lay, unlicensed home birth midwife, and that this is happening at a national level, that we're able to have this conversation. And just to discuss sort of some things that Dr. Stu was previously bringing up, like our hospitals and our system is failing our women on such a broad level that what we've largely created is often women who have the least amount of resources and in many ways less training than other of my medical colleagues are caring for some of the most high-risk patients. And I just want to identify how and why this is happening. So I think naming the problem, that's what we're doing a really good job here, is right, we're naming these problems and trying to think of upstream solutions. And one of the issues that is really unfolding here is if we're limiting what our physicians can do, both because of the compensation model, which obviously that's an ethical concern, right, but also because of the training model, which that also might be a compensation model, also maybe another ethical concern, right, then what's happening is we have the doctors in the hospital that aren't attending breech, they're not attending twins, they're not attending post-dates, they're not attending VBAC, right? And then we have, I will sort of stay out of the licensure midwifery conversation for the sake of this, because ultimately, I'm not actually that concerned about licensure, I'm far more concerned about skill. Because what then occurs is these skills we're actually de-skilling broadly our birthing assistant population. And that de-skilling, which is largely what we're talking about more broadly in women's health, we're not understanding the restorative reproductive model. Our physicians are de-skilled. We're not understanding our nutritional model. Our nutritional providers are often de-skilled. And this is true as well that's happening on the level of who's actually attending births. So then for me, as I've been building my skills over the years, right, now I'm attending a breech mom. Now I'm attending a mom who's 42 plus. Now I'm attending 42 weeks plus. Now I'm attending a mom who's also, 42 plus. Now I'm attending a mom, who potentially, I haven't actually attended multiples at home, but these are the women that aren't, or a VBAC mom, that aren't able to access this care in the hospital. And often the midwifery licensure is prohibiting those licensed midwives, should they even exist in her state, from legally attending that woman as well. So now we've created a scenario where potentially a mom who has maybe has a breech baby, is maybe 42 and has a history of C-section, someone where we might actually utilize some medical metrics potentially, right? That mom now often doesn't have access to that, and so she would end up in my care, right, at home, which I will say, I've attended all of those situations. These babies are all happy and well in this non-medicalized birth environment. That being said, that collaboration is just entirely de-incentivized, and I would argue in many circumstances criminalized both for mothers who are under threat of CPS and criminalized for midwives like myself who are under constant threat of essentially being reported for being, for providing care that no one else will actually provide. Right? So then we're creating the circumstances where now women, what are their options? Give birth at home alone, right? Or go and try to find an obstetrician who will not support their VBAC or who will try to section them when maybe they're not a great surgical candidate to begin with. Maybe they're a poor C-section candidate because they have previous sections, maybe they have this history of complications, but there's actually not a provider for them, right? So this is what we've actually created within our contemporary midwifery culture. And then so often where we're actually struggling is then our conversation is then legislative. Then we're really over here being like, well, what's the answer? What's the answer? Is it more licensed midwifery? Is it more OBs? Is it more, is like where do we actually hone in? What's the legislation? And I just want to zoom us out back to the relational model. Let's name back to the problem really, where I see this problem is a breakdown of relationship. We're not actually in relational care, which has been a theme of our entire day. We need to be looking at this woman. We need to be looking at this baby. We need to be looking at this circumstance, her medical history. And while the problem is large scale, I would not say that the solution specifically for birth attendants is a large scale solution. And where does that bring us as professionals in women's health? How willing are we to be in the ethical, emotional, relational weeds of what it actually means to care for our communities? And to actually sit with the question that maybe our solutions can be informed Like, I'm so grateful that MAHA invited me, that the Heritage Fund invited me to come and discuss this, because I work on a small scale. I work in my community. I have a broad amount of skills, right, that aren't super specialized. And to be here with all of these panelists that are hyper specialized, but then likely what's needed in our communities is someone, if I do say so myself, who has skills like, I can attend your vaginal birth. I can also help you with your breastfeeding. I can also likely assess your tongue ties. I can also do some body work for your baby. I can, do a little bit of cranial sacral. I can help you with your prolapse, right? And I can, maybe see you later when you're having incontinence, because no one brought into your biomechanics in, which I will leave out for today, but I'll plug those as well. But we actually need this return, I would say, to more better skilled, more broadly skilled providers that are actually embedded within a community setting in women's health, right? That have this broad understanding, and we put them in a direct space to speak and be in relationship with patients. And that might not be scalable in the same way. This might be actually in the relationships that we have and in the conversations that we have. So how do we fund that? How do we actually choose that? Well, we become the people who are choosing time over financial considerations, right? We're here to critique it, but we need to be those providers, right? We need to be those people rather than just saying, oh, ACOG does this. And not that you're saying that, you're literally being this provider. But thank you, appreciate you. And so many of us here, where we're actually critiquing these large-scale systems and looking for this large-scale kind of legislative repair, which absolutely, thank goodness that there's so many of us that are working on a policy level. What an amazing policy success we had today in the Supreme Court. I'm not saying that there's not aspects of this, but can we be these providers in our communities? Can we be these advocates for women's health who actually make a different choice in how we relate to our ethics, our considerations, and our maternal fetal health care for the health of our mothers and our babies and our communities at large?
We really are at the end of the day, but if anyone wants to share some final closing thoughts, please do.
I just want to say I do have a handout about vitamin A and fetal development and the things that I said. And what we love in our foundation is to see the scientific validation of traditional food waste. And all of these things that traditional people did, the buildup of nutrition, the vitamin A-rich foods, and also the 3-year spacing between babies, I forgot to mention that, so the mother can recover her nutritional stores. These are all validated by modern science, and that's really exciting.
Oh, I don't have a short comment, so I'll just... Yeah, I mean, ultimately, again, if we wanted to change it on a macro scale, not on... Because I agree with Adelaide, what she's saying is the relationship model, which is the traditional midwifery model. Yes. And the outcomes there are just better, and there's literature to support everything I'm saying, just as there's literature to support twin and breech vaginal birthing. And for whatever reason, ACOG and the medical schools and residencies are ignoring that sort of thing. But what they're doing is even worse than that. I mean, if you take a deep dive into the things that have been done in obstetrics, you find such lunacy. You find out these are supposed to be your experts. By the way, experts doesn't mean what we think it means. It's kind of like that from the Princess Bride, where he keeps saying inconceivable. And I don't think it means what you think it means. Because, I mean, for one thing, I just recently realized when one of my talks about, if you've heard of the labor curve, the Friedman curve. And if you remember your basic geometry, how do you draw a curve? It's dots on a curve. It's like an average. You have a scattergram, and you take the curve, and it goes through the middle of it. And I'm not even going to argue, I'm not even going to make a point, well, I will, that the points on this curve are vaginal exams, which are completely unnecessary for the most part. But what the Friedman curve is used for is if you fall off the Friedman curve as a woman laboring, then you're not moving fast enough. And you need to have your membranes ruptured, you need to start Pitocin, that's how the Friedman curve is used. But think about it again, the curve is the median, which means 50% of women are below the curve. And yet now they're considered abnormal by the medicalized birth model. You know, I could say the same thing about growth restriction, they've changed it to 10%. Everything they seem to do seems to not improve outcomes, but generates more revenue. And that has to all change.
That has to. Can I have one other comment? Okay. So additional factor that I just really, like, it's easy to kind of be up here and critique the way everything works, right? That's very popular, and I also want to add, okay, but what about boots on the ground? Like, what do we actually do when we leave here today? What about those of you that actually attend moms? What about those of you that are working in your communities as healthcare providers that care about this and trying to figure out what to do? The first thing I want to offer is if you are seeing women and they are pregnant, in your first visit, if you're an obstetrician, family med, whoever, in your first visit, can you actually ask this woman how she feels? And then can you tell her that, and give her some examples. Are you in pain? Do you have pain of this kind? Maybe this. I mean, not from this suggestive way, but actually being focused on her somatic experience of her pregnancy. And then introduce the idea that this is going to be something that's going to be followed up on every subsequent visit. This takes 2 minutes, and this is available for providers. And so then you cue her to say, I want you to pay attention. If you're short of breath, if you have pubic pain, if you have, round ligament pain, any of these more common things, right? To then say, will you tell me what that's like when you come back on that next visit? And actually ask her. If nothing else, we could use our time to actually be orienting women, and ideally, right? Then when she says, yes, I still have this pain, you send her to me and I'll help her with biomechanical solutions for these challenges, because so much of that really is an upstream solution for a lot of the complications that we actually see when babies aren't coming through the pelvic pathway. I'll leave that there rather than, kind of go into that topic, but this ability for us to demonstrate that women's sensory experience of their pregnancies matter, right? And that their attunement to their own sensory experience is an incredibly helpful skill for them to be developing during their pregnancy if we want better birth outcomes. We've been talking about body literacy today. We've been talking about how women knowing more about themselves is an essential component of improving our maternal fetal healthcare metrics. Right? So how do we actually do that in a patient visit? We inquire, we encourage, and we give her language, and we give her follow-up, and then we actually follow up, right? And ideally, if not in that visit, I'm not teaching every OB to do biomechanical and posture assessments, though I'd love to, right? Then we are able to provide other resources to actually address how she's feeling rather than simply normalizing every single discomfort and minimizing the canary in the coal mine that is our symptoms, right? Because that's also what we're talking about, in this broader restorative reproductive medical approach, is we ignore symptoms. Women are taught to ignore symptoms, and then we're not utilizing the information that those symptoms can provide to inform the better outcomes that we're allegedly trying to support, because we're not even naming the problem well. And a big aspect of this problem is women not actually having either the questions or the inquiry to feel into their own bodies, to develop their own understanding of what's going on, to be such informed, participants in their health and the health of their babies. So if you work with patients, just that, right? Just supporting that somatic awareness in a consistent and small way is an actionable step that we can all do to be better providers and care better for women and babies.
Thank you so much, Adelaide. Thank you, everyone, for coming. I hope that we have a little bit of time to be social afterwards.